All right. So again, welcome. So as you can see here today, we have again a very healthy agenda with a lot going on in both our morning CAB meeting as well as our afternoon PCC meeting. We will have a break in between the two sessions as we would normally do if we were in person. But here we go, our second time as a virtual meeting. So I very much thank you for your time and the dedication to spend your day with us. And without further ado, I'm going to turn it over to, oops, my wrong thing here. I'm going to turn it over to Peg, our Vice Chair of the CAB, to welcome and call to order. Peg?
Good morning, all. We wanted to thank everyone, one, for taking the time out of your busy day, but also for helping us to launch all of this new technology. We do want to make sure that your voices are heard, so I would reiterate, please use chat. There will be times within the day when Q&A will be open and readily available, but the chat will make sure that we've covered everything we need to cover throughout the day and that no questions left unanswered. So I would ask you to please make sure that you're keeping us on mute until you have the opportunity for the more open Q&A. And I want to thank all the speakers for today because their preparation has been remarkable considering the circumstances we're all in. I would ask for the next slide, please. So this is just our routine note that we have. The meeting is being recorded. The Prevention and Research Advisory Board are public meetings. They're covered under the Sunshine Act. There's no expectation of privacy, so it's not Vegas. What you say here is recorded. And if you need to tap into this for future use or you want to share bits of information, you can certainly go to the PACancerCoalition.org website, and that will give you future reference. Next slide, please. This is our conflict of interest and adverse interest content and information. We want to make sure that you're aware that the board members of the Cancer Advisory Board under the governor's auspice are not sharing pertinent things like RFA, RFP grants or contracts. You know, we really are keeping that information for those groups that can utilize and best benefit. There is no major conflicts, or if there is any conflict, that is recorded on an annual basis and sent directly in. Next slide, please. I would ask at this point in time that the CAB members who are on the call do an approval of the June 11th, 2020 meeting minutes. And if there are any particular questions regarding the meeting minutes, that we voice that at this time.
Orale Dominic approves the meetings as written.
Thank you, Dominic.
Second, Pat Happen-Murphy.
Thanks, Pat. Okay, so we'll move forward after the minutes. CAB business, our first reporter will be Penny Harris, who's the Director of Health Research Office for the Pennsylvania Department of Health. Penny, would you like to take the role and be able to review with us your information?
Sure, I can very much do that. So the reason that I'm here is there were two statutes approved, one in 2017, one in 2018, where there are now funds available for pediatric cancer through donations. One is through the Department of Revenue, which is donations via tax refunds that you can check off and have money given to pediatric cancer research. The other is through PennDOT. When you do a vehicle registration or a driver's license registration, you can donate $5 towards pediatric cancer. Currently, those funds, the revenue fund, as of this week, is at $30,000. The PennDOT fund, which we actually had to check this to make sure it was accurate, is $880,000. And what we would like to do, the statutes are not identical. But what we would like to do is combine the funds so that, because if we wait apparently for revenue to catch up with PennDOT, this could take a while. What we would like to do is combine the funds, the two funds, and you were sent the statutes. They're very short. We would like to combine the funds. One of the statutes references the pediatric cancer hospitals. So what we would like to do is combine the funds, divide them by the 4 hospitals, which is CHOP of Philly, CHOP of Pittsburgh, Penn State Hershey, and the Abramson Cancer Center with UPenn. Divide the funds evenly for each of those, and then have a basic, very simple work statement and budget from those entities, and then provide them the funds. That would make it very easy for us to give out the money, and very easy for us also to receive the reports on what is being done with those funds. So really, we wanted to bring it to the board because the board is also mentioned in both those statutes. So we wanted to bring it to the board to get approval. And what we will do, if the board is okay with this process, we will create a decision memo for the Secretary of Health. And we can certainly send that decision memo for review by the board if requested. And then have the secretary sign off on that, and that will be our process. We don't know how long this the revenue, the PennDOT funds will continue to increase as they have, because we didn't expect this much money. So we will do, we will also send you our plan as to how much money, because if we only have $30,000 a year, it may be very difficult for these entities to come up with a plan for use of that money. However, we might talk to those 4 entities and see if that is just, we'll just do an annual or maybe every other year request from them. Any questions?
No question. This is a CAB member, Aurelia Dominic. Just wanted to thank you for this update. We're excited that there are some funds that individuals allocated for these efforts. I think that's something that we all need to hear sometimes, that in Pennsylvania, we do have individuals responding to reducing the cancer burden for the state. I would like to make a motion to accept the PennDOT funds to be distributed, or as the plan that you have proposed, and to also provide a letter to the CAB members that will be sent to the Secretary for review and approval.
Second. This is Suzanne Gullen. I'd like to second.
All in favor on this?
Aye.
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 Any nays?
Aye.
Okay.
Abstention. Pat Halpin Murphy abstains.
Okay. And so we review and approve. Penny, thank you.
You're welcome, and I really appreciate the work that the board is doing as well. And I'll be glad to provide updates as we know them. So thank you very much.
Okay. We also wanted the opportunity to update the CAB on what I consider to be amazing work in breast cancer. Pat Halpin Murphy has some wonderful news for cancer patients within the state. So Pat, would you like to go ahead and give us an update? Pat, I'm sorry, you need to check your volume.
Is it too low?
Oh, that's great. We got you.
Okay, thank you. Thank you so much, Peg. The Pennsylvania Breast Cancer Coalition worked with Senator Bob Mensch on legislation that would require insurers to cover MRIs and ultrasound for women with very dense breasts. And the background on that is if you have dense breasts, then many times even a 3D mammogram is not sufficient to discover your breast cancer. And we've known this for a long time, and we've been pushing for this legislation. And recently, an article was published in JAMA that chronicled a clinical trial that showed that MRIs are 2.5 times more effective in locating cancers among women with dense breasts. Unfortunately, women now know whether they have dense breasts or not because of previous legislation that we got passed that required mammography centers to notify women if they had dense breasts. Prior to that, most were not. So women now know. And if they have dense breasts, either extremely or heterogeneously, they're the 3rd and 4th highest categories. Going forward, insurers will be required to cover those MRIs and ultrasounds as they would an appendectomy or any other covered procedure. It was a really, really tough battle because we were opposed by many forces, and it took a long time. And what finally, I think, pushed it over the top was that we were able to get 45 out of 50 senators to sponsor the bill and push to have it moved forward. And I want to thank Aurelia. I did reach out to her in her capacity for some background information and also to let her know about this very large clinical trial that showed without any doubt that MRIs are 2.5 times more effective than even 3D mammograms for women with dense breasts and other covered conditions. For instance, if you're a breast cancer survivor, if you there's a whole list of other women who are with conditions that are covered. And Governor Wolf signed it July 1st, which we're thrilled to know. And it's now Act 27. I do want to say that it was a tough struggle getting it through. And part of what we have to deal with is an existing provision of law that gives insurers an extended period of time before this will come into effect. And Peg, you're at Abington, and other hospitals need to know this, and we're going to be sending out information.
Yeah, Pat, thank you so much for that, because we are getting hits. We are getting asks.
Okay, that's great. That's great to know. And
So
here's
going insurer to insurer, there is awareness and then there's none. So yeah, thank you.
Okay, and here's the way it functions. Because of previous existing law, that the insurers have contracts with hospitals, which you're familiar with, and those contracts are for a year or two. And so the insurers don't have to cover it until after the current existing contract with the hospitals and mammography centers ends, and then they have the open enrollment. So there is a bit of delay. We do intend to write to the major insurers and ask them to voluntarily cover it immediately, because that certainly was the intent, our intent, and the intent of the legislation. But within a period of time, I'm going to say 1.5 years, at most 2 years, everyone insured under Pennsylvania law will be covered. And right now, what we're telling folks is, if they want to know if they personally are covered, that they need to contact their particular insurer to see if that particular insurance contract will cover it. And it's very important to find that out, because right before this legislation was passed, we had a wonderful woman, Ruth, who needed an MRI. Her grandmother died of breast cancer. Her mother died of breast cancer. She has dense breasts and two daughters. And her doctor said, you need to have an MRI. So she said yes. She got the MRI. This was several months ago. And she got a bill from the hospital for $4,000. And Ruth is now paying that $4,000 bill off at $140 some a month for approximately the rest of her life, if you know what I mean. Yep. And she's just devastated because it didn't occur to her that something recommended by her doctor and so clearly necessary wouldn't be covered by her insurance, but it was not. And that was the situation with many other women. And now it will be covered. So we have been focusing on expanding and improving screening for women with breast cancer over a period of time. And we're just very happy that this has gotten through. 3D mammograms are still terrific, and you should be getting those as well. We got that thanks to Governor Wolf, who that went into effect about 5 years ago. And prior to that, we got women covered under from 40 to 45 who weren't covered before. So this is a process. And now we're going to have MRIs and ultrasound covered. And we're still going to continue to work on this. And we have some ideas for future legislation. And I'm happy to say that after the bill was passed, Senator Mensch, the chief sponsor, said to us, well, what are you going to do after this? But we have some things in mind. And I just wanted the CAB to be aware of this. We have sent out information, but it's the latest improvement in screening. And I know that the Department of Health is all about getting screening, because they know for breast cancer, it's 95% treatable if you discover it early. And that's the key. So we're going to continue to work on early detection. And if you have any questions, I'd be happy to respond, or you can email me.
Pat, the chair's going to recognize Dr. Golan. Dr. Golan, you had questions.
Yes, thank you so much. I want to thank Pat for her education and advocacy. And as she published, and I mentioned at a previous meeting, I'm here because of an MRI that fortunately UPMC Health Plan covered many years, 11 years ago. And I very likely wouldn't be here otherwise to have the joy of participating in the CAB and helping Pennsylvanians who are cancer patients at risk for cancer and cancer survivors. Thank you.
Thank you. Thank you so much, Susan. MRIs have found cancers in so many women and saved their lives if they have insurance that covers it, and now they will. And I'd also like to mention that we have a virtual conference coming up Friday, October 16th. And we are having as our keynote speaker and prize winner this year for research, Dr. Mitchell Schnall from the University of Pennsylvania. He's head of radiology there, and he's the co-chair of the group that did the clinical trial showing that MRIs are 2.5 times as effective as even 3D mammograms for certain women. So if you want to hear more about it, more detail about the research study, about what comes next, I would invite you all to participate. And every healthcare hero is comped, can come for free to our conference. And we are going to be sending specific letters to each board member and each member of the Cancer Coalition, inviting them to participate as our guest for all or any part of the conference on October 16th. And we want to thank the department for its support in all of this. Thank you. Thank you.
Thank you so much. That's incredibly helpful. And, I can say that it's truly both a pleasure, but also it is magnificent to watch and see how you work through the bureaucratic chains that you go through for patient benefit. I think you've done a remarkable job through the years, and I know that there are women that are eternally grateful because of it.
Thank you so much, Peg. Thank you.
Yep. So good news on the front of prevention and detection and treatment. Next CAB business, could you change to the next slide? So we'll be going into the review for cancer effects among Pennsylvanians, focusing predominantly on liver and HPV-associated cancers. Brenda Anastasio is our Public Health Program Administrator under the Department of Health Division of Cancer Control. So Brenda, if you're on and available, would you like to start your presentation?
Sure, yes, thank you, and good morning, everybody. Yeah, so I'm happy to have this opportunity as a newly selected co-chair for the Data Advisory Committee to share some of this information. I'm going to start out with a bit of a review from some of the information and data that was shared at the last quarterly meeting, and then we'll go into a little bit more detail on some data around liver and HPV-associated cancers. And hopefully that'll tie into some of the information we received later from various speakers. Okay, next slide. Okay, so this slide I put in front of the review slides that you're going to see next. And this is the 2017 Pennsylvania cancer diagnoses by sex, and it's the top 11 and 12, the highest cancers diagnoses that we have for 2017. And you'll see no real big surprises in this slide. The number one for men, males, prostate, and followed by lung, colorectal. Females, we see breast cancer still in the lead, followed by lung and colorectal. One of the things that I'd like to point out is the oral cavity makes the list actually in the top 11 and 12 for both males and females. And you can see oral cavity actually, the rates are higher, the incidence is higher than even cervical cancer for this most recent data. Next slide. Okay, so here, this is a slide that was shown at the last meeting, and this talks about projected diagnoses for 2020. So we don't have we're still in 2020, so we obviously don't have that data, and it'll be a little while before we get it. But you can see the similarity in this projected data compared to the last slide of our actual incidences for 2017. And breast, lung, and colorectal for females, if you compare that to the 2017 actual, there's a slight decrease for breast cancer and a slight uptick for lung and colon cancers for females. And for males, the projected prostate and lung cancers cases are down a bit, and the projection for colon cancer increases. Overall, though, based on the projections, the rates look like they're pretty flat. Next slide, please. And then this is the projected deaths related to these cancers by sex, and the lung cancer being the number one cancer death for both males and females in Pennsylvania, followed by prostate for males, and breast cancer for females, and then colorectal and pancreatic cancers for both sexes. Liver cancer, which we're going to talk about a little more, ranks 5th in males and on this list, and this is the mortality rate, and it's actually on the list for females. So, which I think is important to note, especially when, keep this in mind as we hear from the viral hepatitis elimination folks later today. Next slide. Okay, and then this slide shows the projected site, the changes over a 5-year period, 2015 to 2020. And this slide should look familiar from last time as well for those of you who were on that call. So it shows the trends for invasive diagnosis, and the red, the increase you're seeing, that's liver, oral cavity, and breast cancer rising. Lung cancer, just a slight uptick is projected. And then you'll see a decrease in cervical, prostate, colorectal, and melanoma. I think it'll be interesting to see how the COVID-19 pandemic plays out and affects this data and these projections down the road. Next slide. Okay, and then this slide, I actually really like this. Nathan from the Data Advisory Committee shared this last time as well. And I like it because it shows a really clear picture of cancers that are caught in the early stage versus the late stage. And you'll see starting at the top, and this slide's a little bit hard to read, but you'll see earlier, higher percentages are caught at an earlier stage for melanoma, breast, prostate, cervical, liver. It starts to kind of even out. And then we're seeing a higher percentage of late stage diagnoses for colorectal, oral cavity, and lung cancers. So I think, again, this is something that's really important to keep in mind when we consider access to care and screening, outcomes, and survivorship. Next slide, please. And then this is just a snapshot of how screening was affected with COVID-19. This slide is, the data on this is dated from April, and you can see from left to right, it shows that during that period, there was an 87% decrease in mammogram screening, followed by, an 83% in pap smear screenings, and a 90% for colonoscopy. CT scans and PSA tests were also down. And again, that's no surprise when we went on lockdown. I have been hearing in some of my conversations that health systems have really made an effort to as soon as they were able to reach out to people and reschedule a lot of these exams. So that's good news. And again, it'll be interesting to see when all the data, comes together for COVID as well as cancer, just how it affects things in Pennsylvania. Next slide, please. Okay. There we go. All right, so there's two pictures on this slide here, two data sets. We're going to talk about liver cancer incidence by race and sex. To the left, the bar graph you'll see shows liver cancer. The far left shows all races, and this is from 2015 to 2017. And from left to right, you'll see all races, and then whites, and then blacks with the highest number that's right in the middle, followed by Asian, Pacific Islanders, and Hispanics. And you can see there's really quite a big uptick when with the various races here, Black, Asian, and Hispanic. And then to the right, the donut is that same information, but it's broken down into race and sex. And these bluish, if you start at the top and work your way around sort of counterclockwise. These bluish sections represent males, and the green are females. So we see, again, a higher incidence in males than females. So we have, the higher incidence by race with Blacks, Asian Americans, Pacific Islanders, and Hispanics, and then again here with males. So I think that tells us where we have some work cut out for us. Next slide, please. And then this is just a snap. Whoop, do we have it?
My apologies, Brenda.
That's okay.
All right, so we'll
Gives me a minute. Gives me a minute to pause.
All right, so make sure we get that right slide up.
All right, so, right here.
All right.
Okay, so this just is a snapshot of liver cancer incidence and mortality in Pennsylvania across the state, what it looks like. To the left, the orange map is shows a picture of liver cancer incidence, and to the right, it shows a picture of liver cancer mortality, and this is from 2013 to 2017.
My apologies. And to the participants, if you are kind of pressing any buttons, I'll just ask if you can just be mindful of that. It seems to have a couple times overrode what we have going on here. So Brenda, my apologies again. We'll get us back on track.
Okay. Oop, go back.
One more. All right.
There we go. So yeah, so this is just a snapshot of Pennsylvania and liver cancer incidence on the left in orange and mortality in the right in green from 2013 to 2017. And I did think that this was a little bit interesting because we see the incidence. You can see obviously, the eastern portion of the state, pretty significant, and then the western, particularly the southwest, with less incidents being noted in the center of the state and in the north central. But then when we look at mortality, it's picking up liver cancer deaths in some of these counties where the incidences aren't really recorded. So I found that kind of interesting and something that maybe we should look into when it comes to, again, screening, diagnosis, access, all of those important things. Okay, next slide, please. All right, jumping into oral cavity and cervical cancers. So here we have the blue line at the top of this graph shows oral cavity incidence for males. And again, this is from 2015 to 2017. And then below that, we see the red line, which is the line for oral cavity cancers for females. And then the green line, which is pretty flat line, shows the cancer incidence, cervical cancer incidence. So again, we see a pretty big leap from females to males when it comes to oral cancers. And we see again that oral cavity cancers have surpassed cervical cancer incidence at this time. Next slide, please. Okay, and then here we have it broken down into sex and or race. So the graph to the left shows oropharyngeal cancer incidences in Pennsylvania for 2017. The group to the far left is males, and the blue bar shows the rate for white males, followed by Black males, Asian, and Hispanic. And then the group to the far right is oropharyngeal cancers for females. And then looking to the right at cervical cancer, we see the blue, and this is 2017 also, we see the blue bar indicating the rates for whites, and then the orange for Blacks, and then Hispanics, the yellow. So we do see that there's quite an uptick in cervical cancer incidence by race. Okay, next slide, please. And then again, this is a snapshot of oral cavity cancers throughout Pennsylvania. To the left, we see females, that's in the orange. So there's our incidence map for Pennsylvania. And then the blue map on the right is males. And again, this is 2013 to 2017 data. And we can see just how much more widespread that is across the Commonwealth. Next slide, please. Okay, and I know I'm bouncing around a little bit here. Back to cervical cancer. This is just a picture from the cancer dashboard of cervical cancer incidence and mortality by race, and this is very hard to read. So the blue line represents Hispanics, and the black line represents Blacks, and then the gold line represents all females and all races, and the silver line is whites. So you can again see the incidence on the left, and this is of invasive cervical cancers, is significantly higher for Blacks and Hispanics. The rates for whites it's almost flat. It's been fairly flat. There's a lot of different activity up here for Blacks and Hispanics, and it looks like it's on a little bit of an uptick again here. And then to the right is incidence, or excuse me, is mortality. And again, the black line represents Blacks, and the blue line represents Hispanics. And again, we can see that there's quite a difference in the numbers based on race. Okay, next slide, please. And then here's the incidence and mortality, just a picture again. I think it kind of helps to see, areas in the state where we kind of need to focus our attention. The orange map to the left, this is all females, and that's incidence. And you can see again, the south, the eastern portion of Pennsylvania, and then the western portion with not so much showing up here in the center. And the same for mortality, which is the map, the green map on the right. And then next slide. And then I'm going to wrap things up here with just some immunization data, since it ties in so closely with our oropharyngeal and cervical cancer information. This is the up-to-date data from the NIS teen survey. And we have the light blue, it represents HPV vaccination up to date. And the darker purplish bars represent Tdap, 1 dose, and that, or greater than 1 dose. And that is just, that's in there for comparison, so that, we can see that, here are the number of kids that are being vaccinated for Tdap. To the far left, you'll see it's the United States. And then the second group represents Pennsylvania. So we see quite a big difference statewide from our HPV vaccination rates still when you compare them to Tdap, although our rates have shown an improvement in this last survey. The bars in the middle represent Philadelphia, and Philadelphia has had a pretty robust immunization program, and their reporting is different than the rest of the state, so their numbers look pretty good. And then Pennsylvania without Philadelphia is to the right of that, and that's pretty representative of Pennsylvania as a whole. And then this far right group is new data that we just started getting from the Pennsylvania State Immunization Information System, PASYS, the registry. And I felt like it was important to put this in here, even though we do not have 100%, we don't have mandatory reporting in Pennsylvania, and the system is, there's some issues with that system. It still shows a similar picture. So you can see of all of, and this is for 2019 calendar year, the data on the far right. So of all of the purple represents those that were put in the registry, adolescents who received Tdap, and that same group of adolescents, you can see quite a difference in the HPV vaccination. So, we still have some work to do when it comes to, I think, provider education and, both public and provider education. And next slide, please. So that's it for data, and as I was putting this together, these are some of the things that it means to me, and that is screening is definitely the key to early detection. Early detection, catching cancer earlier, improves survivorship, and that vaccinations are cancer prevention. We see from this information that men definitely need to be seen and screened. And as I put here lastly, but importantly, and definitely hopefully on the forefront of everybody's minds now, is that equity matters. Mm-hmm. And last slide. So I want to thank everybody for their time, and really thank everybody for their participation in these meetings, and for all of the activity that's been going on even during this pandemic. So with that, back to you, Kate.
Great. Thank you so much.
Thank you.
I think you've done a phenomenal overview. And I would ask at this point, are there any questions from the group? I saw one hand up from Dr. Gollan, but if there's others, please let us know.
Oops.
Okay, I think we still need to work on the HPV vaccination. The television commercials are rather effective. I hope at least they catch attention. And I thought that was a terrific presentation. Thank you.
Thank you. Yeah, and I think just pipe in real quick. Obviously with what's been going on with this pandemic, priorities shifted a lot. They were forced to, for the obvious reasons, many of the health systems and providers. But it does seem like there's, especially with the commercials and things that, people are trying to shift back as quickly as they shifted out. So hopefully that'll hold true for vaccinations and screenings, all of this. Thank you.
I just want to say one more thing. What I raised my hand for earlier, you answered the question. Clearly, the immunization database is not very accurate. And so maybe we can work on that. But also now with all the anti-vax sentiment related to concerns over politicization of the COVID vaccine. I just hope that doesn't harm papillomavirus and other vaccination and raise concern among people. Hopefully people will all get vaccinated for everything that is possible and is shown to be safe and efficacious.
Agreed. Thank you. We have one more question from Linda Robertson.
Hi, mine's not so much a question as I just want to thank Brenda. Brenda, the PA statewide immunization data that you provided to me earlier this year actually helped with me receiving funding to continue the work I am doing on P30 with a integrated team. And we are this time around really looking at working with social media. So I am hoping that we can really change some of the anti-vax and those in the middle, their perceptions and maybe some of the myths they are holding in relation to HPV vaccine. But without that data, and I know you worked hard to get that data, I'm not sure we would have been funded. So thank you so much.
You're welcome.
All right. So ready to move forward, Peg?
Yes, please. Thank you. We did want to give everyone the opportunity to hear an update about health equity in action. So Dr. Sharnita Ziegler-Johnson, Chrissy Villania, and Kate will give us an overview. And then Kate, if you want to run, organize your speakers through this, that would be really helpful. Thank you.
Absolutely. Well, thank you, everyone. And this, I think, is something super timely for discussion and following some of the data that we are seeing across the state. And Brenda, thank you for that last point in your slide around equity matters, because that is so true. And that is really part of this discussion. As all of us on this call are very familiar with the terminology and what it sort of the phrasing of health equity and something that we do hold close. So today is much more about a discussion or how else we can dialogue and really try as a coalition in the work that we're doing, especially moving forward to further our work with lessening those gaps in health. So this is really not the only time that we want to have this conversation, but really using today to sort of kind of move us on a journey as we go forward into our next year planning and the next 5-year plan. So just kind of kick off, and I think everybody knows me, but I'm Kate Mostowski, co-chair to the Pennsylvania Cancer Coalition, and my fellow speakers today include Sharnita Ziegler-Johnson and Chrissy Villania, who are our leadership to our disparities subcommittee, who have been doing incredible work and super supportive of all the work that we're doing across our coalition and others, advocates for patients and communities, and you'll hear both of them talk about this as well. So just to kind of kick it off and give a little bit of a background. So it's last year, the American Cancer Society and Robert Wood Johnson really committed together to be much more intentional in our work moving forward around health equity and put together some tools and resources that is kind of some of what we are bringing here today. So again, welcome and thank you. And we are excited for this conversation. And as a coalition, as mentioned, this is really part of a journey that we are working towards to be even more or work towards even more health equity. So through our partnerships, both new and existent, we know we can be even more intentional. And before we get into this, I just want to take a moment and talk about why the American Cancer Society. And so, and I think this is, everybody can appreciate and relate to this, but we know for our mission and really the work, not only for the mission of the American Cancer Society, but really all of what we do, we know that we cannot fulfill that mission if, or of a world without cancer, unless we make sure that everyone has a chance to prevent, find, treat, and cure or survive cancer. So in fact, while everyone is affected by cancer, it does not affect everyone equally, and that is not okay. And we can't achieve our mission if we do not deal with this head on. And that is why we are talking about this today. And I know as a coalition, we will aspire to build that world and really looking at what we can do across the continuum to bring those spaces of access and lessen the gaps that we are seeing. And just really looking to make sure that there's a fair and just opportunity for all. So today is finding how each of us can continue to support that and really work towards where we are to know where we need to go. So at this point, what I'd like to do is turn it over to Sharnita. One moment. Who's going to take us through a little bit of how we can accelerate that process.
Good morning, everyone. So how can we accelerate the progress in reducing cancer mortality and inequities? This is work that each of us is so passionate about as members of the coalition. We have dedicated our lives to issues outlined in some of these articles, which were all co-authored by members of the American Cancer Society. We are working across the cancer care continuum, from prevention to screening and early detection to treatment and clinical trials to survivorship and surveillance. And we work across various levels with different patient groups and advocacy groups, educating communities, clinicians, and government officials in the state about ways that we can accelerate progress in reducing cancer mortality. We examine biological factors that increase susceptibility to cancer and environmental and behavioral factors. But let's be honest, right now we are in an interesting current climate with social justice issues, again at the forefront. And we have to admit that America was built on a foundation of inequality. Again, we're facing the ugly past and our ugly present of discrimination, racism, inequity, acknowledging that groups in our society have been dehumanized, oppressed, ostracized, overlooked, and neglected, while some others have been privileged with better life opportunities and opportunities to live healthier lives, and perhaps opportunities to survive a cancer diagnosis. So an important focus of our work has to be in addressing the social determinants of health: income, education, housing, career opportunities, availability and accessibility of healthcare, and social environmental factors that impact the success of any of our cancer-reducing policies and programs, because these are the factors that contribute the most to health inequities. Next slide.
Thank you, Sharnita. So this slide, though you'll see on here, this is what the American Cancer Society had identified as our health equity goals and the vision in which we hold. And this is definitely something that parallels our thinking as this stakeholder team, very aligned to our plan and our work. And so you can see, just like we would for any sort of program and planning, that we have broken these into short-term, intermediate, and longer-term goals, including really increasing our knowledge of health equity, enhancing our capacity to advance this work, and really uplift the current work and be much more intentionally integrating health equity into our plans. And so that's where, as we sort of move into the next parts of our agenda, what we want everyone to consider. So I'm going to advance to the next slide. And these three areas here are really part of the journey in which we will be taking you today. So we will briefly cover some content around why disparities exist to gain some of that deeper understanding. And we're going to dig a little deeper through some discussion. So we really hope that there are folks who will come off of mute and really help drive some of that conversation. And lastly, we will leave you today with some of what our work has been. So that's something, as we kind of started off this session with, this is something that we are working towards, and, the challenges in front of us to go deeper. We have been doing and paving the way here in Pennsylvania, and we want to acknowledge just a snapshot of some of that great work. So we will do that as well. So now, Sharnita, I'm going to set you up. I'm going to flip over to the video, but I'm going to go out of the PowerPoint to then bring that up. So I'm going to turn it over to you to start speaking as I pull up that video.
Okay, thank you. So we're going to watch a YouTube video. This is Michelle's story. She's going to tell us a little bit about what her life has been like. We'll look at some of the factors that have influenced some of the decisions that she makes. I think we'll get started and just think about some of the factors influencing her health decisions.
Fantastic. Sharnita, are you able to see my screen as the video?
I am.
Fantastic. Wonderful. And I hope everybody can hear. Please let me know in the chat if you were unable to hear.
We don't hear it.
All right. Let me try that again. I think I know what I did wrong, and I'm going to go ahead and give that a whirl one more time. My apologies. Virtual meetings do not come without a bit of technical issues. Oops. Pause that again. All right, I'm going to start this again. Please let me know if you
got to change.
Are you able to hear?
I live in a community that was so prosperous with doctors and lawyers and politicians. Now we have drug dealers and corner stores that they don't sell anything but the wrong things. You cannot deny the impact that it has on people's health. I had been in West Baltimore my entire life. As far as money, my mother didn't have any money. I don't want to say she was poor, I'll say low income. Poor we were though. In the 50s, we didn't have many choices as far as healthcare. The healthcare system then was limited. It was not good for us. And medicine costing so much that my family says sometimes, will I eat or will I pay for my medicine?
Which one do you want?
Oh, I just love my daughters when they come over and we get together and we cook and prepare meals together. It's healthy meals. When my oldest went to college, she came back with a different diet.
Now what happens is if I do a meatloaf, it's turkey instead of ground beef. You know, I make spaghetti, I make chili, stuff like that. It's with turkey and chicken.
We grew up, we ate pork. We ate bacon, we ate a fresh shoulder, we ate pork chops. I did not think it was not healthy eating. Right. Because this is what we were accustomed to. I was in denial. I didn't want to face the fact that I was becoming a diabetic.
The impact is the fact that my family ended up with heart disease, emphysema, diabetes, cancer. My mother's sister, her daughter died of diabetes. She was an amputee. My mother died of a massive heart attack. And
to address health disparities, we need to understand why they exist, that they're not due to one single factor. They're the result of policy decisions we make as a society. They're due to the environment, health education, insurance and access to care, access to healthy food, and stress. Those stresses are actually experienced disproportionately by people who are poor and people who have been historically disadvantaged in this society.
solutions to these problems cannot just be medical, it's systemic. And that means everybody has to get involved.
If we want a nation to be strong, the people in that nation have to be healthy. They have to be well. If there's anything that we can do to stamp out disparities, we need to do it by any means necessary.
Hi, Ms. Simmons.
Hi, Doctor. Here at East Baltimore Medical Center, most of the patients are underserved.
Do you need nice deep breaths in and out through your mouth?
Michelle is a terrific success story. There was actually a year where she had lost her job, and before she found a new one, she had no health insurance. And she still managed to buy her medicines out of pocket, paid out of pocket to come and have doctor visits. She was really invested in her own health. That's something that Dr. Cooper's research is looking at, why patients don't invest in their health like we wish they would.
The next thing on the agenda is the community update, so I'm going to turn. Michelle joined our community advisory board in 2011. We provide education to the community about health and about research. We offer training programs for community health workers we can be sure that we are meeting the needs of people appropriately and that we're not leaving out certain groups of people that have traditionally not been included in conversations related to health and healthcare. Our strong relationship with the community is just essential. There's no way that we could do what we're doing without their input. And my work is just one of many initiatives here at Hopkins.
Good to see you too. Ms. Simmons is a great example of what happens when we get it right as clinicians and as an institution.
I am a fighter. I am a believer. I stand for what's right. And what's right is people's health. And I will never give up as long as I have breath in my body.
One of the things that is so important is that people have what I call a liberated future. And it's hard to be liberated when you're not healthy. And when I say liberated, I mean freedom to be all that God meant for you to be. When we don't deal with disparities, then what we're doing is denying people an opportunity to give back to the world. And so we've got to fight it. We've got to fight it with everything we've got.
Very powerful video.
Right. Thank you, Kate.
All right, I'm going to bring the other slides back up, Sharnita.
Mhm.
Bye. We're going to stop that. Sorry. Gotta love YouTube. All right, let me bring it back to the slides here. Okay, just 1 minute as they're coming up. All right, Sharnita, you should see the root causes of cancer disparities.
Yes, I see it. So we do have some discussion questions here, and that's just really to guide your thinking. I want to ask you, though, what really resonated with you? Was there a particular part of Michelle's story that resonates with you? And you can use the chat, or you can raise your hand, you can come off mute, whatever you want to do. This is the time when you can really just interact and discuss with us, with one another. And there are no right or wrong answers.
It's Suzanne. I think that the daughter coming back with the diet, the dietary changes, if we could do more community education programs in church, well, once COVID's over, in church basements or with various chefs to help people in the community learn how to cook lighter. I think we could all benefit from that. The diabetes prevention program at the University of Pittsburgh School of Public Health is a really great program. And actually, I took it along with other faculty to essentially learn about the program. And without any difficulty whatsoever, 3 years ago, I lost over 20 pounds in 6 months without trying too hard. So I think there are a lot of programs around that really benefit the community in terms of healthy diet and getting the community involved in their own health, in our own health. Is an effective means. How to do it is the question.
I love that. Thank you. I think that's so important. And that resonated with me as well. You know, sometimes we have to get out of our, into some other communities and see how other people are doing things. But one thing that really hit home for me was the mother talking about the importance of meat and eating lots of pork when she was growing up, and how they didn't know it was unhealthy. Because I know that's something that was true for my family and my upbringing as well. And my parents and my grandparents talked a lot about food insecurity when they were growing up, and very often not having meat. So when they could give it to us, they made sure that they did, and that for them was giving us a healthier diet. And it's something that you have to kind of change your mindset about, but it's generational, and it comes sometimes out of that food insecurity that was, coming from multiple generations of just not having and not knowing and not being able to do it differently.
I'm sorry, Trinity, you bring up a really important point about generational challenges and poverty and the experience that we ultimately have, and how do we retrain generations? Part of the work we do today is really meant to plant seeds in generations moving forward, that ultimately a lot of the issues we experience regarding disparities go back so long that we have to retrain so many folks and teach parents to teach children who will teach their children about food, about healthcare, about so many things that ultimately resonate across the board when it comes to outcomes for folks in their health.
Right. Thank you. And I see some other hands that came up. Let me see. I can't tell. Kate, can you tell who else raised their hand? I saw a couple.
I saw that one was Jim PC.
Jim, can you come off mute? Kate, am I in control or are you?
Sorry, I was muted myself.
Oh.
So Jim, if you could try to unmute yourself. We'll try to unmute you from here. Okay.
I have a comment if we can't get Jim on. This is Pat. Jim, are you on?
Yes, go ahead, Pat.
Yes. The cooking with the daughter attracted my interest as well. And I was thinking about a program in Philadelphia where they're taking kids, perhaps 4th, 5th grade, and doing cooking lessons with them. And they prepare a meal for one another, and they do it for, I think, over like a 6-week period, with the idea, one, that they will learn to like lighter foods, as Susan said, more healthy selection of foods, and also how to prepare them. They're very simple recipes and things like that, and then take them home. And I'm just wondering if there's any thought of focusing on younger children as a way to introduce healthy foods into a family.
Yeah, I think that's a great idea. I think you need that one person who can be influential and really can change how everyone else eats. And the child shows interest, the parent shows interest in changing. My daughter recently showed interest in changing her diet, and she's also a college student, but it really did make a difference in how I now eat. And my husband's showing a little bit of interest in changing his diet. And it just takes one person sometimes.
Yes.
I think that's
if I may, my granddaughter has become a vegan. When she visits, obviously, I try to, of course, have foods that she will enjoy. And I have adopted some of them. I can't say I'm a vegan or a vegetarian, but it did introduce other possibilities. For instance, dinner without meat. So, maybe some of us who are older are pretty well set in our ways. But if the younger daughters or granddaughters or grandsons come home and say, oh, look what I found. That might be one way to approach it.
I think that's a great idea. Okay.
Chair, this is Dr. Dominic. Can I make a comment and a question?
Absolutely.
Thank you, Chair, for recognizing me. First, I wanted just to thank the presenters. This is just phenomenal. I really do like that minority health disparity video, Michelle's story. I love the subtitles that remind us the impact of certain comorbid conditions. And was wondering, Chair, is this something that we could possibly leverage for Pennsylvania and have this being led by CAB in specifically creating a video highlighting all 67 counties in Pennsylvania and adding one or extending this format to also add the rural component? We know that 52 out of the 67 counties are rural Appalachia, and that represents over, 47% of the population here in Pennsylvania. And if we could have institutions that are here in Pennsylvania, the lives of individuals that live both in inner city as well as suburbs and rural versus urban, I think that would be phenomenal. And I was wondering, is this something that we could leverage and move forward with and produce something like this for Pennsylvania?
I actually love that idea. I know Christy and I were actually having a discussion because as we were looking for videos for this presentation, we had a difficult time finding things, especially related not only to equity, health equity, but also diverse and to cancer specifically. So it was very difficult. So I think that's needed.
So Sharnita, to answer both you and Aurelia, there are programs in the area that we absolutely need to highlight. So I can tell you within the Asplund Cancer Pavilion, we have a food bank, and we have a food bank for cancer patients, and we have it because they're exhausted. They have difficulty with nutrition and food choice. They have difficulty with learning to cook. We do bring in their loved one, their spouse, their significant other to go through the nutrition and information with them. But we also offer them what is in the food bank that they can prepare that night as a starter. And I have to tell you, it's huge. We fed over 100 families. It's just phenomenal.
So, Chair, may I make the recommendation that we make it official that CAB will embark in these efforts to create a minority health disparity with a cancer focus across the 67 counties, and I would be one of the individuals that would be willing to lead these efforts.
Awesome. I would ask for a vote from the CAB.
Am I allowed to make my own motion? And have someone second? Okay, so I make the motion that the CAB will do a statewide video capturing minority health disparities and rural and urban across all 67 counties, that we will stay in close communication with Christine and others who have already embarked in these efforts, and that we will highlight across our state the institutions and the stories of the lives that are being impacted, both with success stories as well as challenges in all 67 counties, and that CAB members will lead this, and Oralia Dominic spearheading this and welcoming anyone else who'd like to join these efforts on the CAB.
I'd like to second that motion.
Yeah, and I would agree wholeheartedly. Aurelia, it's a great idea.
Thank you. And we will have a timeline that maybe this could be our Christmas present or our holiday present. So we will work on this with the intention that it would be a deliverable for 2020, and then embark in the new year as we start to learn additional impacts of both COVID-19 on all industries and the communities that we visit, that it will also expand. So thank you so much, and we will connect offline in terms of what the next step would be.
Aurelia,
Thank you.
Pat,
Yes,
did you
please.
make the
Go
motion?
ahead, Dr. Gollin.
Peg, I would like to comment that we do have a health disparities team on the Cancer Coalition, and they should be integrally involved in designing this. So I just wanted to add that. I feel very strongly about that.
Thank you. Duly noted. And as leading this effort, I will reach out to our CAB as well as our, I think it is, I want to just say the name correctly, and I believe it is the PCC, which is the Prevention Coalition Controls, the PPC. Great. So I will be reaching out to Mark, I believe it's the co-chair, to Linda, and then also we will, if it's okay with Chair, I will put together a communication email that will also go out to all the CAB members and have them also have direct input into this deliverable.
Pat, and so did Lynn Robertson.
So this is Monica Fisher, and this is a very rich discussion. And as I've heard you talk, what I was thinking about, I was trying not to say anything because I'm DOH staff, but what I wanted to share with you all is that as an African-American woman, 2-time breast cancer survivor with a genetic defect for breast cancer, for cancer in general, and thinking about the food, the things that stood out for me was, I would like those of you, first of all, food for all cultures is really just this gathering place and this meeting place and this place where we share what our culture is. And what was interesting to me is that for African Americans, our what's really called soul food, that is so much a part of our culture. And what I need dominant group members to understand is the background behind that, so that when we approach these conversations with people, we aren't approaching them just simply like their stuff is wrong. We need to have more representation from people of color like myself, because some of the background of that is that Black people started eating those types of foods because that was all that was available to them. Those things that were considered scraps and not important, those are things that we made delicacies that we now see in high-end restaurants costing a lot of money. So what I appreciated was hearing the woman talk about substitutions, where I could still have my cultural identity for what this food means to me in my community, because I'm the cook in my family. And I cook all of that. Even the stuff I don't eat, I cook all of it. So I don't want to take a lot of time. But what I would ask for you to do is consider really being inclusive of those of us who are a part of the community, and really on your own studying what, in addition to that, what that history behind those foods have meant to us, so that you can shape ways that are honoring our cultural impact with health and food, and at the same time offering us options so that we don't necessarily feel like you just trying to tell us how to eat. And I don't know if that makes sense, but I wanted to put that out there. Thank you.
No, Monica, that makes total sense. This is Peg. When we sit down with families for their loved ones, we take a cultural inventory. You know, if your world includes X amount every week because that is your true love, how can we blend that in appropriately? And will there be any impact based off of your treatment that would cause a problem for you with that food? If not, can we do a substitution? That makes total sense. It's great.
Peg,
Thanks.
it's Nicole Blannard. I just wanted to
Nicole,
make the
please,
mention.
go ahead.
Yes, I just wanted to make the mention, and I know Chrissy Valenia is well aware of this program. We have to leverage the resources we have, and given that we are in many rural counties, we've set up what we call the fresh food pharmacy. So it kind of benefits all involved. Our local farmers are able to get their produce out and about, and our folks are able to go get it. A lot of it's free of charge. And we've taken it into the areas that may not normally use fresh fruits and vegetables, for example, but it's had some significant impacts in some of our lesser served areas, and in more of the areas that it's harder to get. You can't just go to a Trader Joe's and get organic food, for example. So it's important to leverage what we have in the communities, and that's been a wonderful resource for us. So just another program that we want to look at, throwing it out there for kind of watch and learn and see how we've done things right and wrong with the fresh food pharmacy, and it's been a really a good blessing, and it's been good for all involved. Just wanted to share that.
Oh, Nicole, wholeheartedly. I think there are best practice methodologies throughout the entire state.
Yep.
To us, the link is how can we get it out to the people truly in need, and that's phenomenal. Mm-hmm. Thank you. I also see Linda Roberts.
Yeah.
Linda,
this is Auralia Dominic. Just wanted to comment. Everything that was said, I just made note of, and I will be sending you an email as well to the CAB members to make sure that we not only hear these suggestions, but we act upon them. And two things come to mind. Maybe the video can say a tour of PA. Learning the culture, the values, the beliefs, and the richness in these communities and in the lives that we touch. And at the same time say, here's also a taste of PA. And then Monica and others that have those special recipes that are passed down from generation to generation, how we could somehow still enjoy those, but being conscientious about how we could continue to lower our risks for cancer, or even if someone already has it, how to improve the survivorship. So I love this tour of PA. I love the taste of PA, and I love the stories of PA, both our successes and our challenges, as well as our windows of opportunity. So I'm excited about this. I'm going to mute myself so we can continue with the agenda. But thank you, Chair, and thank you, everyone, for your support, and I look forward to working with you for this deliverable.
Good morning. Can you hear me?
Hey, this
is Hi, Jim.
Good morning.
Good morning. We can hear you.
Oh, good morning. Thank you. I had microphone problems on this end. Jim Williams from the Pennsylvania Prostate Cancer Coalition. I enjoyed all the comments that have been made thus far, but I'd like to approach this subject from the 60,000-foot level. I think we find more and more that the business about health equity, disparities, and race, we know that this whole classification of race is a social concept, and that from the scientific standpoint, it has little to do with our biological situation. I think we need to look at it from a national security point of view, especially when talking to decision makers and trying to get adequate funds to do all the great things that have been suggested. If we're going to stay number one in the world, we must have a healthy and educated population. And we're spending tons and tons of monies in those two areas, but as you look at our return on that investment compared to other developing countries, industrial countries, we find that we don't show up as being number one or number two. We have a sick care system, we don't have a health care system. And so we talk about all these good things we need to do in prevention and health behavior, but when it comes down to the monies, most of the money is put into the hard science. And that is definitely needed, there's no doubt about that. But I'm of the view that every time we talk about hard science, we need to know that 5% of our problem with most of our diseases is based on biology, and 95% of it is based on environment, as we've been speaking about this morning. So in our clinical trials and in our efforts, we need an arm, always need an arm for quality of life and for survivorship. And the behavior sciences, which is considered in many cases the soft sciences, really don't get the priority they need to bring their information forward, which addresses the things that we're talking about this morning about behaviors of people in their health behaviors. And so we need to make sure that our decision makers understand that this is not just a good thing to do or a nice thing to do. It's essential if we're going to stay strong and healthy as a country.
Well, Jim, I can tell you, wearing my healthcare system hat, this is a huge priority, because if we can't get our patients to be fed appropriately, we can't treat, and therefore we can't cure. I mean, it is a huge priority to make sure that we're looking at all barriers to care.
Well, I'm glad to hear that, and I hope from the national level we can have the funding available that equates to the high priority that you're talking about. So I guess my point is, we talk about the community and our liaison with the community, but I think we go to the same sources repeatedly. I've just come up with a list of 21 African American minority organizations in the Harrisburg area, and I know that we do not have liaison with 21 African American organizations in the Harrisburg area, and I'm quite sure across the state to make with our various programs.
Hi, everyone. And this is a really important discussion and really good dialogue and ideas. Sharnita, I'm going to kick it back to you in the interest of time, and we can, if there's folks that still have your hands raised, we certainly want to allocate some time to come back to this discussion. But I definitely want to kind of throw it back to Sharnita for any final thoughts on this slide.
Oh, absolutely. This was such a rich conversation, and it was wonderful. I even had a new initiative come out of this, so I'm so thankful. Just wonderful to be able to think about what are the barriers that our patients, our neighbors, that we might even face. We're dealing with cancer, we're dealing with healthcare, and how we can overcome them. And knowing that this is multidimensional, that we have family, that there are communities, that we have faith groups, as you saw in the video, and there are providers. So there's lots of dimensions to this, and we need to tap into all of them to move things forward and to overcome the barriers that our patients face. So
Peg,
we can move on.
Okay, Peg, I've had my hand raised for a while. If I can make a comment, a procedural question. Did Aurelia make a motion? Was it seconded? And did we vote on it? And can you hear me?
Yes, I can hear you, Pat.
And I want to say that if we have a motion, a second, and if the CAB votes on it, the Pennsylvania Breast Cancer Coalition will contribute $1,000 toward this video, because it affects everybody, and it particularly affects women with breast cancer. And so, but I think I heard Aurelia say, could she make a motion? I didn't hear a second, and I didn't hear a vote. And so I'm asking you a procedural question.
Right. So I did hear a second from Dr. Gollin, correct?
Yes.
Correct.
Okay. So do we take a vote?
And we can certainly vote. So all in favor of this motion?
Aye.
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 Okay.
Any nays?
Thank you so
Any
much.
nays, any abstention?
So the motion passes. Congratulations, Aurelia.
Thank you.
Thank you, team.
And I think even from what we can see here, there's such a conversation that's to be had, and the continuation of this. So, we really thank everybody for this kind of starting point and the hopes. And I think I can speak for everybody, the continuation of what this will be as a coalition, as we sort of dive that deeper as we go forward in this journey. In the interest of time, I'm going to kind of go quickly through the next few slides and just reference them, but I'm not going to go through them. They'll be there in the slide deck for everybody, and we'll provide links to where they are, because we have another video to show you too. Let me move this forward. So when we just kind of think about just what the landscape looks like in the sort of space of cancer disparities, as no shock here that these are ones that we have noted even throughout, that cancer is something that affects everyone, but it does not affect everybody equally. And from a nationwide perspective, we can see those statistics here. What I also wanted to just reference very quickly was that we are seeing very similar patterns in our state of Pennsylvania. I didn't put the exact statistics in here, but what I will say is we saw from a really incredible data presentation earlier, our Department of Health has a wealth of data available to all of us, and we could really look at this. And in fact, a lot of these came from our 2019 cancer burden report for the state. And included also in the same place was the BRFS data. That's some notable disparities in there too. So we, just want to make that reference there for folks. The sort of other thing, it goes without saying, as we all know all too well this year, if I could ask everybody, if you're not speaking, if you can make sure that you're on mute so we can eliminate that background noise. Thank you. The impact of COVID-19 on our cancer patient community and survivors. So our ATS-CAN team earlier this year did put out a survey, and the respondents, there's a lot of information in here that just showcases pretty much the immediate impact that the pandemic has had on cancer patients. And, we're continuing, of course, to see what that does look like. I think all of us are really, paying attention and seeing what we can do to kind of pull it all back. But I just wanted to reference this. This is something, we'll provide that information. We'll get that into the link as well, so you could read this at your leisure.
Kate, I heard yesterday a new study is showing that 70% of children under the age of 20 who are dying of COVID, 70% are Black, Hispanic, and Native. 70%.
Yeah.
Speaking of health disparities across the board, of course, we're worried about cancer here today, but overall, this just really shows the significance of disparity in our country.
Absolutely. And Chrissy, I think just even on the heels of just your words, what we are seeing not only in cancer patients, and even, with what we even saw just on all of the things that sort of shape what impact looks like for individuals, it goes without saying that pretty much every aspect of this, and even the gaps that were existing before, they're widening. And, we've even talked about some of the things that we have done we had to pause a lot of things because of the pandemic, and, we're moving mountains, our healthcare teams and others are moving mountains to get people back to where they were or where they want to be. But we have a long way to go. And I think we're all paying a lot of attention to what this will look like and transcend into disparities, or what we can do to hopefully keep the gap from not widening, as it's already very wide. So as mentioned, all of this stuff will be provided in follow-ups. I didn't want to spend too much time on past these slides, but the data is there, and there's journal articles and stuff like that we need to get out to you. So at this time, I would like to turn it over to Chrissy to take us through another section of our conversation. So Chrissy, the floor is yours.
All right, super. So, I'm sorry, there's definitely someone who is not muted out there. I can hear some background. If you can kindly take a look at that. So, as we talked about disparities overall, I'm a social worker, a patient navigator at Geisinger. I work in Pottsville and Hazleton, so Schuylkill and Luzerne counties, both places that have their own very specific sorts of issues associated with those people in those communities. And so the disparity subcommittee is incredibly important to me. And we have a video coming up just to highlight a bit more about what's happening. It's just a few minutes, but to really open up the significance of some of the issues facing everyday folks every single day associated with their cancer journey.
All right, so similar to what we did for the first video, I'm going to take us out of here to be able to play that video. So if you bear with me for one moment, we will go ahead and do that. All right, and same as before, please let me know if you cannot hear this.
As the daughter of a survivor, I know how very important it is to make sure you do those self-exams. In the shower one night, I decided I would do mine, expecting to find nothing, as always, and then my fingers found it, and my knees buckled, and I sat on the floor of my shower for what I thought was hours. I was unemployed. I had no health insurance. I was broke in more ways than just financially, and I had no clue what I was going to do. That was when I found this amazing program, the Breast and Cervical Cancer Early Detection.
We lost the sound.
All right, let's try that again.
If you're having problems, we can just move right along with it, because the important part here, you know, we're really crunched for time. And
Yes.
the important part here, she's talking about the breast and cervical cancer program, lovingly known by me and many social workers and peers around the state as BCCPT. We utilize this program really importantly for those folks who have no insurance during a time of breast cancer or cervical cancer, and it's a thrill, you know, when I'm able to. I've done this twice this month already. When I'm able to offer this to a patient who is experiencing a change in their employment or something has happened, I feel so relieved when I know that breast and cervical cancer program is available for folks. But allow me to say to you that that is just for breast and cervical cancer. So there are numerous, you know, and Brenda's presentation earlier highlighted the significance of oral cancers, colon cancer. We experience a lot in Pennsylvania, lung cancer. There is absolutely no backup plan for those folks who are experiencing a change, you know, in their insurance status. And unfortunately, in America, our insurance is frequently linked to our employment. And now COVID, on top of everything else that someone might be experiencing, a new diagnosis often leads to a lack of employment due to some reason. You know, you're ill, you're getting treated. So I bring to you that I love breast and cervical cancer program. It's incredibly important to my role, to my work, to my folks. But we don't have a backup plan. And so when we were preparing this presentation, it was important for me also to note that there are so many big, giant, gaping holes in our system for people who are experiencing a cancer diagnosis. For example, when you can no longer work due to your cancer diagnosis and you've decided to apply for Social Security disability, we're grateful when that goes through. But keep in mind, if you have an advanced cancer and you have been approved for Social Security disability payments, you still have to wait 6 months until that payment comes through. So 6 whole months that you wait, many people without any income or very limited income for those periods of time. And something that's even more stunning about that is that you do not qualify for insurance. And when you become disabled in America, you can qualify for Medicare, but you don't qualify for Medicare until 2 full years. Consider this, 24 months after your very first payment of Social Security disability. So there's this big, wide, gaping hole for folks who are experiencing a new cancer diagnosis, a loss of a job. You know, they're sometimes very advanced in their cancer. They have little income, and now they may have no access to insurance. This is really such a huge issue for us. So, you know, I ask the marketplace, I'm grateful that it exists. It is still very expensive for people who have no job. Also, many of those marketplace plans and even our employer-based plans come with large out-of-pocket. Have you ever looked at your own insurance to see what your max out-of-pocket is? It can be really overwhelming. It can be daunting for people when they find out that they may owe $7,000 or $8,000 per year. So come January 1st, while you're in the middle of your cancer treatment, you may gain a brand new $7,000 out-of-pocket. These are stifling, overwhelming feelings for people who are experiencing cancer diagnoses. Here, the next slide, please.
All right, absolutely.
So this slide remains a favorite for me because I live in the universe in which equality does not equal equity. And this is a daily reminder for me, specifically because so many of the folks who I work with experience trouble with transportation. So despite the fact that I work in Hazleton, and Hazleton proper is a decent bus system, but consider, you've got to get on a bus, and so you've got to walk, and so you've got to, you know, you're sick, you're going through chemotherapy, and now you've got to wait at the bus stop. Well, what does that mean? Or perhaps you're using medical assistance transportation program, but you have pain, and so you get picked up at 7 a.m. and your treatment is at 9 a.m. and now you have to wait until 1 p.m. for your pickup to go home again. We're grateful the programs exist, but there's very little equity associated with those programs. It is a blanket program that exists for people, but it does not cut across the significance of what people are experiencing. So keep this in mind when you are forging forward with your own programs. When you're thinking about how do I make this available and feasible for people, consider equity, not equality. Yes, it's available, that's equal, but how is it equitable for folks who are experiencing chaos and new diagnoses and illness? So this will always be something at the forefront of the work that I do. And when I first joined the PCC, it feels like many moons ago, I joined the Access to Care team. And the reason for that is how do we make sure people even get care in the first place? So I'm always grateful when someone has Medicaid in Pennsylvania because the medical assistance transportation program exists. But just like we said a minute ago, there's zero equitability across the board for that. Many people really struggle with getting on those buses. In many of the counties of Pennsylvania, Rapid Transit is a provider for that, and that's fantastic. But it still can be a very long day for people who are not well. And something else that is really shines bright in the state of Pennsylvania, which is a very decentralized state. So many counties own the significance of their medical assistance transportation program. Each of these counties has a different application process. Each of these counties has a different process of how to schedule a ride. And some of those counties do not offer actual equitable access. So I work in Luzerne County, but in Luzerne County, where in Hazleton, we've got more than 50% of people who speak Spanish, there is no Spanish application in Luzerne County for medical assistance transportation, nor is there a person on the phone that you can call to schedule a ride in Spanish. It seems crazy. So in this world in which many healthcare systems are trying hard to make sure that we're able to speak with people through interpretation systems, systems that are set up across the state are not doing much of the same. And so there is a lot of big gaps in access to folks. And keep in mind also this program, it seems crazy, for medical assistance, right? So frequently people who have medical assistance or Medicare early in life is because they're disabled. Disabled transportation frequently doesn't cross a county line. So if you're in a rural county and you've got to get to a cancer center, you've got to jump through hoops. And if you can't find a person like me who can help you figure out how to jump through hoops, you may not get to your care. And unfortunately right now, Road to Recovery, which is a really important program for all of us who work in oncology, is currently not driving. So we miss it terribly. We hope it comes back soon. We hope COVID goes away. And lastly, when we think about transportation, Uber and Lyft are fantastic. And it's something that the Access to Care group was talking about an awful lot. And these things do exist, but if you don't have a credit card or if you don't have a smartphone, you can't really actually utilize these programs. Next slide, please.
All right. Thank you, Chrissy. And now, Sharnita, I know that you're leading us with some of the points that we have here, so I'll turn it over to you.
Yes, thank you. In the interest of time, we won't do a lot of brainstorming here. We'll just talk about some of the obstacles that already came up. Transportation is one we just discussed. During the course of our discussion, we've mentioned education about health, affordability of care, prioritizing health care, whether or not individuals trust our healthcare systems. There could be other obstacles that we encounter, language barriers, all sorts of things that some of our patients encounter in getting care. So my question then is, what are the opportunities for our coalition? What are things that we can do to decrease some of the disparities that we see and to reach more of the communities that need us to promote health equity in those communities? Any ideas?
I'm thrilled about the consideration of doing this new video. Sharnita and I had some back discussion about how little there really was focusing on what we know we see each day. So it's a thrill to know that the coalition and the CAB support these efforts. As a disparity subcommittee, we hope to continually cross-cut through our groups to make sure that people are asking the right questions and addressing, making sure that there aren't any gaping holes in your great programs that you're planning on launching. So it's just a thrill that we're going to work on this together and share it as a whole. I'm excited about it.
Absolutely. Linda, I see your hand up.
Hi, thanks. Everything has been great. This is work that I do on a daily basis. And I think what I feel is missing, I think all of our efforts are great, but if we don't get more collaborative with those on the ground, those people that are in these communities, and that, I put a plea out for all of us. We need to get more members involved. Those that can't become members, that's fine, but we need to develop relationships in all these minority-based communities so that we hear their needs from their mouth, because they vary per community. Some of them are general, but a lot of them vary per community, and we need to work with them on those levels. And I am hoping that someday, that with all the work Pat Halpern Murphy has done, that we are able to do similar in addressing all these obstacles, but we only can do it by empowering our community. That's my thoughts.
Absolutely, thank you. And actually, it's one of the things that recently came up that Sharon brought up for us to work on, the disparity subcommittee to work on with the membership subcommittee, to bring in more survivors and patients and community stakeholders to our coalition. So we'll see what the next year brings. That'll be a priority for us.
Thank you.
Okay. Any other suggestions, other opportunities for us?
Shanita, this is Peg. I think we have an opportunity with the various navigation teams that are throughout the state, both for those that are clinical as well as those that have true community connect and benefit. They are an amazing group and really are those people that might be first touch to a patient who may be looking for either screening or cancer services, in which case they are the people that need this in their hands first and foremost. Mm-hmm. Because whether you're an outreach navigator or whether you're a clinical navigator, you are the one who's kind of driving the bus to get people to the resources that are needed. So we do have a navigation team within this group. And I do think that this is an excellent opportunity to forge an even better working relationship and a resource toolbox to be able to really help them.
I like that idea too. We have a resource toolbox already.
I think each group in their various counties have their known resources that are tried and true, or they have new grant funding and therefore new opportunities. I would strongly suggest we outreach to the navigation experts in each of those areas and do that assets inventory. That will give you an updated toolbox by county.
Well, we do also have a Pennsylvania Patient Navigation Network that is a grassroots organization of those of us who do this work, and so we can also reach out to all the right folks who handle that and see if we can get some input there too. Boots on the ground are important for sure.
Great, thank you. I see some hands. I saw Jim, and there was another. I can't tell who.
I will ask if we could maybe just have one more. We are running a little over, and then if you could put it into the chat, any of those that we don't get to, and we will definitely want to continue this conversation.
Okay.
I see Joanne Senft.
Okay.
Yes, here we are. I just wanted to mention that, and I know Gene Langrich is on the call as well, and he could expound on this. But as part of my work with Penn State Cancer Institute, I've been directly involved in making calls to women associated with one of our practices within the medical group that is more of a disparate population. I can tell you firsthand that it has been very challenging to get women out to get their mammogram, childcare, elder care, health problems, comorbidities that are going on in their own lives or with a spouse. Very, very difficult. I want to give a shout out to my coworker, Lorna Lamel, who is with the team ROAR, working with community health workers who have been invaluable to offer transportation to these ladies to get them in for mammograms that are sometimes overdue many, many years. So just seeing it firsthand directly, I'm with everyone who said we have a lot of work to do.
Mm-hmm.
Okay, thank you so much. Thanks, everyone. Next slide. Okay, so just to reiterate, the mission of our disparities subcommittee is to reduce disparities in the Pennsylvania Cancer Control's implementation activities to address availability, accessibility, affordability, and accommodation of healthcare across all individuals affected by cancer. And we want to do more than just look at race, ethnic differences, which is often what we can do with the data that's available in the Pennsylvania Cancer Registry, but to also consider differences and disparities with regard to income status, insurance status, LGBTQA+ status, rural, urban differences, immigrant, undocumented status, religious minorities, disabled, non-English speakers, incarcerated, those who have been incarcerated, homeless community, and other stigmatized groups. So that's a lot of people for us to consider, a lot of people who often are neglected in some of the work that's being done around the country. So let's keep those all in mind as we move forward. Next slide.
Absolutely. All right. So one of the things we wanted to do, as we sort of close out today's discussion on health equity is what we as a coalition currently have going on. So what we have asked our various work groups to do is prepare a slide each to showcase some of the work that they are doing, really reflective of health equity in action. I know I said 2 minutes on here to share, but I will ask if we could, the designated speakers for those slides, if you could really be very mindful of the time and maybe pare that down to under a minute if that's possible. So first up, we do have HPV vaccination. So I believe, Joanne, that you are the voice of the group.
Okay, I'll try to go as quickly as I can. So this is a list of, this slide represents initiatives that we're currently in progress or planned for the very near future. Just to paraphrase here, the Pennsylvania Immunization Coalition, in partnership with the Pennsylvania chapter of the American Academy of Pediatrics, they are promoting HPV vaccination through a statewide mobile marketing campaign. In Southwest Pennsylvania, UPMC, another one of our partners, is launching a social media campaign to increase HPV vaccine update in their catchment area of 29 rural and underserved counties. Continuing, the city of Philadelphia is promoting HPV vaccination through a successful social media campaign, their target audience being parents and adolescents in a very disparate population. Dr. William Callow, one of our partners with Penn State Cancer Institute, he is leading an initiative to increase the adoption of evidence-based communication strategies for HPV vaccination in rural primary care practices. Dr. Jennifer Moss, also with Penn State Cancer Institute, she's leading a program focused on overcoming barriers to HPV and colorectal cancer screening among women living in rural and segregated communities through some self-sampling. Dr. Sarah Ramirez with Penn State Community and Family Medicine, she's involved in a program involving self-sampling for HPV among Latinos in central Pennsylvania. And finally, last but not least, Fox Chase Cancer Center is involved in studies focused on parental awareness and hesitation of HPV vaccine among Asian populations. So I'd just like to say that our HPV work group benefits greatly by the diversity of our work group members. And I'd like to thank our co-chair, Pam Schauer, and all of the work group members for their contributions and the work that they're involved in to increase HPV vaccination and decrease HPV disease. So moving forward, we just plan to build on these listed initiatives as well as further develop our partnerships such as oral health, pharmacies, pharmacists, and community health workers to address these health inequities.
Thank you, Joanne. All right, next, Lynn, if you could come off and share a little bit about the colorectal cancer work that we have going on.
Okay. On behalf of Laura Toole and myself, Laura, who's not able to be here today because she's recovering from surgery, hip replacement, we are doing a lot regarding colorectal cancer within our subcommittee or our subgroup. And we chose to just kind of focus on a couple things, though, to highlight. So although the goal of our work group is to deliver the message about colorectal cancer to everyone who's eligible, a number of our committee members, and probably the majority of them, are really focused primarily on free screening for individuals who are un or underinsured. This includes strong collaborations with FQHCs and FQHC-like clinics, and it's our ultimate goal to reach everyone who is eligible. And some of us are working in collaboration with health systems so that if colorectal screening, whatever it may be, but particularly if it's stool-based, that we can then offer those same individuals free colonoscopies if indeed they are positive, and work with them through navigation if indeed they need further help in other types of insurance getting insurance or getting coverage if something is found. So as we are moving forward, we currently are pulling together best practices and strategies that have been successful during the pandemic to maintain colorectal cancer screening, one of which you'll hear today. And some of our members are in the process of developing large outreach campaigns for colorectal cancer screening during this time. I personally and some others are actually working to develop a large campaign across 29 counties in southwestern Pennsylvania. Thank you.
Thank you, Lynn. All right, next, if we could have Caitlin come up and share a little bit about the lung health group.
Hi, so the lung health group has two projects kind of focused right now. One is the MOVES, and this project provides no cost rate on education, testing, and mitigation services for low income communities specifically in the Allegheny County area. And the education is going to be done through virtual town meetings, and also radon testing can be done during the cooler months, which is coming up. So the other one is partnering with the Racial and Ethnic Minority Sub-Work Group. This sub-work group project is focusing on distributing PPE care packages in the Allentown area. So with that subgroup, we are looking to partner with them to expand the MOVES project mentioned above, to have that expand into the Allentown area. And this partnership really just kind of got formed, so we're really excited to see where it goes. And there hasn't been much conversation yet, but we just kind of started those conversations. So we're excited to see how else we can partner. But that's kind of what's going on with the lung health work group right now.
Thank you. All right, next we have cancer genetics and genomics. And I don't know if Andrea Durst or Alana was able to attend today. I'll give a moment to see if they were able to come off mute if they're here. And if not, we can share their slide. And just a little bit about that. So as you can see here from the slide, there's a lot going on in the space of genetics and genomics with our team, and looking at what they are putting together as far as providing more resources to our care teams, patients, and providers to really continue just what that looks like and impact in this space. And so as you can see for what they plan on moving forward, there's a needs assessment survey that will be of the providers and the public in PA that's looking to happen in 2021. So we'll really look forward to the results of that. All right, so next up we have our survivorship quality of life. And Susan, I believe that you are our spokesperson, so if you want to come off of mute and share a little bit about that.
Yes, thank you. Can everyone hear me?
Yes.
Okay, great. Yes, what we're doing with our survivorship plan is our Live Strong at the YMCA program pre-COVID was in person, and then as we switched over the end of March, we continue to provide services virtually. And so now what we're trying to do, and we've had very good, solid outcomes. What we are getting ready to do and kick off is we are going to offer our next session totally virtual. We are going to be able to reach out to everyone in Pennsylvania to see them sign on, since Megan and myself are trainers, certified trainers nationally. We are able to do the virtual programs along with our staff that are trained. And so this is going to break down our barriers of not being able to reach people in remote areas. So we feel that our big thing is making sure that we are accomplishing our access to care through being able to combat some of the issues that we've had in the past. And that ties in with what we're going to be doing moving forward. Like I said, the only problem that we, and you can see on the screen here, is we're addressing problems that we don't want anybody not being able to take part of the program if they don't have the technology that they need to be able to sign on. The past sessions that we had, we did not have any difficulties with that, but we are working with different organizations and companies to be able to see if they will provide during the 16-week program, if they can provide us with the technology and everything that's needed so that we can reach anybody, no matter where they are located, that they can take part in the program. They also receive still, thankfully, a lot of the YMCAs in Pennsylvania now on a limited basis are open, so they are able to go into the facilities too if they're enrolled in the program.
Wonderful, thank you. Just noting the time, we are above 11:30, and so we are officially going over. So if you all could bear with us for a little bit, we still have some great things to share and taking us home, but we'll keep moving forward. So one of the other groups, of course, that we wanted to showcase today was our men's health group. So Jim, I don't know if you're still on, if you wanted to just share very briefly what is going on with this team too. If you're not able to come off of mute, I'm happy to share that great stuff. All right, so I don't know if Jim is able to, oh. Okay, so what we can see, the priority of this work group is prostate cancer, and really looking specifically at how Black males are having the highest risk of prostate cancer and the sort of impact that has on diagnosis and late stage disease. So they're really doing a lot of education, really the stressing of the message of having those conversations with the care team, really to address that particular disparity. And moving forward, they're looking at the engagement of those community influencers to see how can we bridge the education and the needs around the various things that we might see culturally, linguistically, for awareness.
Kate, can you hear me?
Oh, hi, Jim.
I'm sorry, I'm having microphone problems here. Yes, I think our major focus is we've identified, we keep talking about community. We're trying to identify other African American and minority organizations in the area that we don't usually have liaison with. We've come up with a list of 21 organizations within the Harrisburg area that we're going to make liaison with and introduce them to CAB and our programs. And many of these organizations are women because although we're talking about men's health, the women are the ones who influence their men to change their health behaviors and to get the necessary screening. So we're quite excited about the opportunity to take this program and reach out to organizations that traditionally we haven't communicated with. And those organizations include such organizations as the African American Chamber of Commerce, Ken Curtin branch of the YMCA, which has a health program, the Order of the Eastern Star, the National Council of Negro Women of Greater Harrisburg, just to name a few of the organizations that we traditionally have not had liaison with, but we do now. So although we're in a pandemic and our means of communications have been limited, we hope by creating and exercising the virtual opportunities that are available that we can bring these organizations into the fold. Also, just other comments. I know that I was cut off before. Many times when we talk about the community, we really need to look more at the zip code than the so-called arbitrary community, because health disparities is more about zip code than it is about racial identification. And so I think within the Department of Health, we have identified health disparities and those concentrations of cancers by zip code. And I hope we are using that zip code analysis as we target our communities. Thank you, Kate.
Thank you, Jim. All right, so really great stuff that's happening. So I'm going to, for some final thoughts, turn it back to Sharnita and Christy.
So as we wrap up today, I'm just appreciative that everyone was interested in hearing more about this. It's obvious that our committees are really looking, and our work groups are really looking at the importance of disparities in their work. And the Disparity Subcommittee will continue to work with everyone in regards to this. I just want to remind all of us, because I think so many of us who are on the Pennsylvania Cancer Coalition are professionals and are people who are working in big institutions. That it's important that we never forget to ask the people who are doing the work and the people who are needing the work, that we make sure that we're asking those folks. There are lots of programs that start from up high, and once they trickle down can be really complicated. So just making sure that you're all thinking when you're creating new programs to address some of these issues, that you're asking the right people. Ask all of the people, everyone in your organization, but especially those who are doing work. Keep that in mind.
Thank you, Chrissy. And thank you, everybody, for this important conversation. We look forward to continuing this not only in our individual work groups, but across our coalition. So next, I'm going to ask Peg if you could come off of mute.
Here we go, Kate.
All right, Peg, I'm going to turn it over to you.
Right. There are certain experts that have helped to guide us through things like our 5-year cancer plan, our ability to work with these magnificent groups. And we really wanted to thank and appreciate Mark Wojtowicz for his incredible value, his incredible contribution, but most assuredly, just Mark thinks strategically. And that's what this group really needed. We are forever grateful for the amount of time, effort, and energy he's put in to making this such a successful cancer coalition. He's remarkably bright and talented, but more important, he gets the need in his community. So Mark, we thank you for everything that you've been able to achieve with this team. We wish you well in your next endeavors, and please continue to help us in your guidance and your expertise. We really appreciate all the work that you've achieved. Kate, do you want to say anything? Because you've been his partner in crime as well.
Well, I mean, you said it so eloquently, Peg. I mean, it has been just such a joy to learn to be led by Mark, and just to be able to, as a co-chair, be a partner in this work together. It has been an incredible road. And Mark, I cannot thank you enough for all your guidance and your leadership, and look forward to sort of what, as Peg had said, those next steps and how you will continue to be that impactful voice and influencer to the work that we do. So thank you.
Yeah, thank you so much, everybody. It has been really my pleasure to serve in this way. Not only, be representative from my organization, but also, serve the state and all the communities across Pennsylvania, through the work and collaboration of everybody that's been involved in the then stakeholder leadership team to now the Pennsylvania Cancer Coalition. So I think that, listening to everybody's input along the way, trying to kind of, pull together a number of the things that we have in common between some of the work streams and aligning them, and really just being the best version of the PCC that we can be. Knowing what, there certainly are limitations, to what we're able to bring as far as resource. But I think the possibilities become endless when we work together and we think about, how we can achieve and achieve objectives and move forward. So it really has been my pleasure to be able to kind of get a high level view and contribute to the coalition work in this way. And I look forward to remaining involved and continue to work with all of you in this regard. So thank you very much.
And thank you, Mark.
Thanks so much, Mark.
All right, so Mark, you can stay on because you are next on our agenda too, as sort of that officially passing the baton.
Yeah, so again, it's really been my pleasure to have been a co-chair with Kate Miskowski and also Karen Saunders from the Northeast Regional Cancer Institute in my kind of tenure. And I'm really happy to help announce that Lynn Robinson is going to take over as our new co-chair along with Kate. I'm really excited for the energy, enthusiasm, and expertise that Lynn really brings to leadership for the PCC. And I think both Kate and Lynn will leverage every bit of this PCC to pursue opportunities, create new ones, bring people together, and really, advance our mission here in Pennsylvania. So I'm really thrilled that to share and really pass on some responsibilities to Lynn Robinson. Thank you.
Thank you, Mark. So Lynn, if you could come on and give you some space to share a few words also.
Thank you, Kate. And Mark, thank you for that wonderful introduction. Though, as much as I'm honored to take on this role and to be working collaboratively in another way with Kate, because Kate and I do a lot together and have done over the years, Mark's shoes are really big to fill. So I'm a little bit anxious also, but I'm happy to assume this role. And for those of you that don't know me, I currently and have for many years served as the Associate Director of Health Equity and Community Outreach and Engagement at UPMC Hillman Cancer Center. My work involves 29 counties in Southwest Pennsylvania, and I have a strong background in oncology, but also leadership, clinical expertise, and research expertise. And I saw Eugene's comment. Myself and my team not only does work in the communities and clinically, but we also do basic research and are involved in basic research related to health equity and disparities in cancer. So I'm hoping that some of this can be brought to the table with as we move forward with health equity. So I'm really excited about all of this. And as I said earlier in earlier comments, that I think we have a very strong foundation with the PCC that we've developed. I've been involved almost 10 years now. And I think now's the time that we really have to get our community involved, and particularly our minority, be it whatever, through race, ethnic, SCS, whatever type of groups that are underserved, and we see healthcare inequities and cancer-related inequities involved, because that's the only way we're going to be able to move all of our efforts forward. So thank you very much, and I look forward to working with everybody.
Thank you, Lynn, and thank you, Mark, and thank you, Peg. What a wonderful morning we have had. Lots of content, really incredible conversation, and we look forward to continuing that. As we said, much of that really transcends into a lot of what we'll be moving forward together. So what I would like to extend to us now is probably, a time for us to break a bit, get something to eat, a drink, or what have you, before we bring to you an afternoon filled with a lot of really incredible content and wonderful expertise. So if we could take this opportunity to break, we will reconvene and kickstart promptly at 12:15. So thank you for bearing with us as we went over a bit, but we look forward to seeing you again in about a half an hour. So 12:15, please hop back on. So thank you, and we will see you soon.
Mommy has to go downstairs so she could get some lunch. Some lunch.
Hello, it's Oralia Dominic. I'm going to mute my phone. I'll be back in about a half hour. I'll mute my phone.
Hi, everyone. If you are on, we will begin again at about 12:15. Thank you. Megan, I don't know if you are on and can hear me. If you wanted to try to come off of mute if one of the numbers I see is you.
Can you hear me okay? This is Megan.
Hi, how are you? Good, I can hear you perfectly.
I'm so frustrated this didn't work out. I'm sorry. I don't know. I'm on vacation, so I guess I don't know. Microsoft isn't working with my computer. So as long I can see the screen, I'm signed on, but just visually. And if you think that you can hear me okay, then I'll just present audio through my phone and follow the
Absolutely, whatever you want to do. I do have your slides uploaded into here, so we can make sure I'll advance them for the team. And yeah, as long as you can see everything and we can hear you, then I think we're all set.
Yeah, I guess more my concern is that you might not be able to hear me. So at any moment, please interrupt if you can't hear me okay.
Not a problem, not a problem. Virtual meetings, they always bring a little bit of this and that.
I don't know why I always have issues with Microsoft Teams. We usually use Zoom, and then I've used WebEx too, but for some reason, and maybe it's because I always use a work computer, and maybe it like won't let me download the full app.
And I will say from my work computer, and we have it on there, but if I try to link from my Outlook calendar, it prompts me to download an app. It's very interesting considering I already have the software downloaded. It's just I completely understand.
So what I was trying to do was actually log on rather than just log on through my Outlook and access it through Chrome. I went in remotely into our network to see if I could do it there, and it wouldn't let me do that either. So this is what we're stuck with.
Well, as long as you direct me on what you want me to do as far as advancement, I think we'll be able to be all right.
Okay, sounds good. I will certainly let you have your well-deserved break. I'm sure you've had a busy morning.
Oh, I'm just sitting here, just enjoying the time and of course the conversation. Yeah, it's good. I'm excited for this afternoon. All right.
So, Kate.
Hi, Monica.
You know, I was not able to directly chat with you.
Right.
And I was not able to access the separate chat that we set up for each other. And it was really weird. I was getting an error message that just said it failed to send.
Yeah, I think it's just been a little bit tricky today.
Yes.
But I think so far, and thank you for the monitoring of the chat, and of course coming off and joining that conversation, which was so incredibly important. I'm so glad that we were able to have that this morning.
Yeah, that was excellent discussion. You know, I was scared to come out, but I was like, nope, this is just really sitting with me. So, but I wanted to know if you had the opportunity to try that download participant list feature.
So I'll talk to you post meeting about that, but I do have a list of participants. So
okay, great. Great.
Yeah. So yeah, I think what we're doing is we should start having some of our speakers, as you have heard, Megan, she's on, Mendez Miller, she is on, and then we'll just wait to see what other speakers are logging on. I see Lynn is still on, but she might be on a break.
Right.
So, and we're still recording, even as through, just I didn't want to lose anything. So we are still recording during this period of a pause.
And that'll be helpful for me as I do the notes of the meeting. So,
ladies, you're doing a wonderful job.
Thank you, Sharon.
Thank you, Sharon.
we just, oh my God, if people would just mute their phones. Oh my God.
Sharon?
Yes.
Sharon, we're still recording.
I know. I'm watching what I'm saying, but I'm just saying people would just mute those phones.
Yes. Yeah. It was, I think, really important conversation this morning. I'm excited to kind of hear what's next. And I'm already talking with Sharnita and Chrissy on that very conversation. But really good stuff. Hi, everyone. If you are joining us or rejoining us, if you could just let me know that you are here as a speaker. If our speakers for this afternoon are on, that would be very helpful just to know that you're here. Megan, I know that you're on. Lynn, I don't know if you are back. Okay. All right, we'll check those if others are on. Dr. Miller, I see that you're now logged in. How's that going?
I'm logged in so I can see the slides, but
Oh,
not
okay, okay.
still using your audio.
Very good,
I
very
can actually, Kate, I don't know if you'd want me, it looks like there's a button where I can take control. So if during my presentation, if you want me to, I can advance my own slides, I think.
I mean, I'm happy to do that. I handled it this morning. That if you want to just say next slide, I'm happy to do so. There was a couple of little things that happened this morning where I have no idea what, technology things. So if that's a comfort, I'll still do that for you, and run any sort of technical interference should we need to do that for you during your presentation.
Sounds good. And how much time did you want me to talk for?
So I don't, and I know that you were talking directly with Lynn, what her sort of time, the coaching that she had shared. So
I have 15 minutes stuck in my head. I
Oh,
don't know.
okay. That's probably then perfectly on spot.
Okay.
And then what we'll do if it's set up for you this way, if you would like, we'll just kind of do a Q&A for anybody that has questions post presentation. So we'll kind of let you go through all of that, and we'll have everybody hold until your conclusion.
Okay.
All right. Hi, everyone. If you are hearing me, and you're a speaker this afternoon, would you be so kind as to just announce your name, letting me know that you are here? Dr. Miller, I know that you are here.
Hi, this is Lauren Orkis.
Hi, Lauren.
Hi.
Susanna Massardis with the Community Liver Alliance.
Hello, Susanna. Thank you.
Hi, this is Yolanda Murphy.
Hi, Yolanda.
Hi, Ruth is here as well.
Hi, Ruth.
Kate, are you still there?
I am, Monica, yes.
Can you please send Dr. Christopher Manley the invite? I just sent you an email with his email in it.
Absolutely. Let me do that right this minute. All right. Hi, everyone. If you are one of our speakers this afternoon and have not yet announced that you are here, if you could let me know either via the chat or by coming off of mute, that would be great. We'll get started in just a few moments. Lynn, are you there?
I'm here, Kate.
Fantastic. Lynn, we're trying to get Dr. Manley back into the meeting. We just,
okay.
Yeah. And Dr. Miller is here.
All righty.
And so is Lauren and Susanna.
All righty. But we don't have anyone here yet for CRC, I guess, huh?
Dr. Megan Mendez-Miller.
Uh-huh.
So she is here. She's
here.
Yeah.
Oh, I'm sorry. Yeah, you did say that. I'm sorry. I guess in the essence of time, I'll make their introductions kind of very short and sweet.
Sure. So I guess, it is 12:15. So if we want to kind of officially reconvene, we'll do a little bit of a restart of our meeting if everybody is all right with that.
We're ready.
Okay. Well, welcome everyone back to our meeting, this time of the Pennsylvania Cancer Coalition. So thank you all for this morning and just really a wealth of conversation and dialogue. It was really just something, and I really thank you for all of that, and we'll continue that important conversation. As we move into this afternoon, we have a tremendous number of speakers who will be providing their expertise to each of you this afternoon, and that will help us with this sort of continued dialogue from this morning, and then of course what does come post meeting. Just really quick before I turn it over to Lynn for our first panel, just a couple of things. If this is your very first meeting, I guess I should start and say who I am again. I'm Kate Mostowski. I am the co-chair to the Pennsylvania Cancer Coalition, and I'll welcome you officially to our afternoon session of our coalition. So as mentioned, we have a great afternoon planned. What I will say, if this is the first time that you are meeting with us, or if you are not officially a member of our coalition, we would of course love to have you be a part of that. And if you were part of the dialogue this morning, you know that really expanding and diversifying our coalition is something that we are looking to do and eager to do. So there, in follow-up, will be provided a membership profile form that we would ask that if you wanted to officially be a part of that we would want you to fill that out, so we make sure that you are in that communication moving forward. The one thing I will say as we sort of move from this morning to this afternoon and post meeting, because where we are with our annual meeting, this is a time where we are usually coming together to talk about what's next year's plans and activities. So what will happen post this meeting today, kind of from today through the end of October, is that within the space of the various work groups, you'll be in touch, or your work group chair will be in touch with you to schedule some time to go over potential activities or thoughts and those incredibly important conversations that we do have to move us forward as we get ready to submit again to CDC. And this, as we sort of, bridge a lot of the dialogue from this morning and post, will help us even with the further thinking when we do start to plan for our next 5-year plan. So we will be getting that writing started soon. So as mentioned, post this meeting, over the next few weeks, your chair will be in touch to reconvene your groups. And I think that is where as far as business goes for our meeting, where I will end, and I will officially pass it over to Lynn Robertson, who will welcome in our first panel, which is really going to be centered on prevention and screening. So Lynn, floor is yours.
All right, thank you, and welcome everybody back to the afternoon session. I just want to say a few things about primary prevention and early detection. Primary prevention and early detection through improved awareness, early clinical diagnosis, and organized screening for selected types of cancers are key components in cancer control, and I know we're all well aware of this. But these efforts in turn can lead to decreased cancer incidence and mortality. However, although there are many strategies for early detection and prevention and their availability, many individuals, for whatever reason, choose not to get screened or encounter many barriers to screening for a variety of reasons. So our speakers today will share various strategies that they have implemented and have been successful in increasing colorectal and lung cancer screening. And we're also going to learn more about hepatitis and the increased incidence of liver cancer throughout Pennsylvania. So what I'm going to do is now welcome all of our speakers, because as we saw this morning, time goes very quickly. So I will introduce all the speakers and then we'll proceed with the presentations. So the first speaker will be Dr. Megan Mendez-Miller, and she has numerous years of experience as both family medicine clinician and a researcher with current active research in approaching colorectal cancer screening in vulnerable populations. She works with women's and immigrant health and does medical education for both students and residents. We have for lung cancer screening, Dr. Kumar, who is the Associate Professor of Medicine in the Division of Pulmonary Critical Care at Fox Chase Cancer Center of the Temple University Health System in Philadelphia. And he also serves on the National Comprehensive Cancer Network Lung Cancer Screening Panel. Let's see. Then Lauren Orkis will be presenting on viral hepatitis and elimination planning, and she leads viral hepatitis prevention and surveillance activities as the viral hepatitis prevention coordinator at the Pennsylvania Department of Health. She has a doctorate in public health with a focus on epidemiology. And then we have Susanna Mazurtis. I'm horrible with names and I apologize. And she's going to talk on the Hepatitis Free Coalition. And she is a consummate professional whose career spans more than 25 years of progressive and nonprofit experience. She's the Director of Development for the Dollar Energy Fund, as the Corporate Officer for the American Cancer Society, and the Executive Director for the American Liver Foundation. So if you all join me now in welcoming our speakers, and I'm sorry if I missed anybody, I'm going based on what I have as bios. And if I have, please feel free to speak a little bit about yourself. So we'll start off with Dr. Miller and colorectal cancer screening during the pandemic.
Hi, everybody. I'm actually speaking through the phone, so please let me know at any point if there's feedback or you can't hear me. I know we are talking about the pandemic, but there were certainly a lot of barriers that came up with this program, and that's what this program was all about, was overcoming barriers towards our local community. So Tom McGarity, who I think many of you are familiar with, reached out to me through a local colleague, and we formed a partnership where we're bridging the gap between our academic health center at Penn State Health and our local community. And most of our grounds so far have been with our local FQHC, Hamilton Health in Harrisburg. And now we're starting to develop similar type programs with free clinics surrounding in the central Pennsylvania area. So I'm with the Department of Family Community Medicine. Dr. McGarity, who I think many of you know, is the Department of Medicine Division of Gastroenterology. And Mary Noel Palisock is an MD PhD student who's really led a lot of our student efforts. And Dr. McGarity and Mary Noel will not be able to join us today. Next slide, please. So I'm sure all of you know, in order to overcome barriers and do things, you need a lot of partners. Penn State College of Medicine, Penn State Cancer Institute, Milton S. Hershey Medical Center, Hershey Endoscopy Center, who is affiliated with Penn State, but actually kind of staffed by our GI department, does the endoscopies. Highmark is a partner of Penn State and has provided funding, as has the Association of Family and Friends with Penn State. We've also gotten grant support through the community health team based on their community health needs assessment in central Pennsylvania. And our largest funding has been most recently over the last 6 months from a CTSI grant through Penn State. So, and then at the bottom are our two partners so far, Hamilton Health FQHC and Beacon Health Clinic, which is a free clinic in Harrisburg, as our new partner with this program. Next slide, please. So a lot of this is probably known to you folks, but these slides are pulled directly from the CDC, and stats towards cancer statistics from 2017 in Pennsylvania, and of course colorectal cancer is high up there on the list with new cancer causes as well as cancer deaths. Next slide, please. Some more stats. That little box there is Dauphin County. That's where Penn State Health and Harrisburg is located. Next slide, please. And I think it's important to talk about, and I'm sure this has been spoken about today, about the diversity of cancer. And so, here's some stats according to Dauphin County, where we're located, with different ethnic backgrounds related to colorectal cancer. Next slide. So there's basically, according to guidelines from American Cancer Society, Gastroenterology Societies, Family Practice Societies, and USPSTF, the United States Preventive Task Force, on options for colorectal cancer screening. So of course, going right to a screening colonoscopy is the preferred. That's the gold standard. That obviously becomes a barrier for a lot of folks related to transportation, funding, underinsurance, lack of health care, lack of literacy, of health literacy. I could go on and on about barriers there. So other options are a FIT DNA test, or Cologuard, as it's more commonly known, a flexible sigmoidoscopy, which has fallen out of favor but is still valid, a series of fecal blood tests there in the office or sent home, and then we decided to focus on FIT testing, which is general guidelines are annually for every 3 years. Next slide, please. So again, the background, there's an example of a FIT test. A patient gets this sent home with them, and we like this approach for our basic screening. Number one, as we were partnering with our FQHCs, this is part of quality with federal qualified health care centers, where this is an effort in their primary care and cancer prevention. And it certainly makes sense for other free clinics that we're partnering with. FIT kits in general are affordable, and they're easy. We hand them out, we take the patient's, or the participant's phone number, and we ask to call them later, and we follow up with them, and we find out, did they send in their FIT kit, and we chase down those results. And from there, if the FIT is negative, you're good to go for another year for colorectal cancer screening. If it's positive, then a lot of our program, and really a lot of Dr. McGarity's part, has been where do we go from there? How do we get the diagnostic colonoscopy for a positive FIT screening? Next slide. So why do we screen? And again, I'm preaching to the choir on with this, but of course, all about colorectal cancer screening is to prevent colorectal cancer. If we find a polyp and its stage before it becomes adenocarcinoma, certainly that's preventing colorectal cancer. So screening for colorectal cancer is a very important effort. Next step. Next slide, I'm sorry. So risk factors that we know of, African Americans or people of Black background are 20% higher incidence than Caucasian counterparts for colorectal cancer. Mortality is 25% higher in males. And of course, increasing age has a lot to do with it as well. Like most cancers, we can increase incidence with increase in age. Certainly medical history, and this is Dr. McGarrity's specialty, is genetic backgrounds or chronic diseases, either Crohn's or ulcerative colitis, familial polyposis syndromes, which set people up for higher risk for colorectal cancer. Social history, again, like most cancers, excessive alcohol consumption, and then hereditary syndromes like we discussed. Next slide. So with Hamilton Health and our partnership, the reason this came about is Dr. McGarrity, I think, was chatting with some of his GI colleagues in the area, and somehow he got wind of our local FQHC, Hamilton Health, having a backlog of patients who had a positive FIT screening but were not able to proceed to a diagnostic colonoscopy. So this idea kind of planned in his head, and for those of you that know Dr. McGarrity, he just asked. He went to Penn State Health and he said, hey, can we scope these patients for free at no cost to them? And Penn State Health said yes. And then he said, well, when we find cancers, which we're going to find, are we going to be able to, at no cost to the patient, be able to commit to treatment of their colorectal cancer? And he also got a yes there. So that was the beginning of the project. So Tom really worked with Hershey Endoscopy within his GI division, internal medicine, and leadership at Penn State, kind of facilitating how do we move forward with scoping people with positive FIT tests from our local FQHC. And through a connection of ours, Judy Dillon, who's my mentor, those of you who may know her, Tom reached out to me because he didn't really know how to tackle the other piece. How do we get these people from Hamilton Health? How do we get them their prep? How do we get them transportation? How do we get them an escort? Because with a colonoscopy, with any endoscopy, normally you receive anesthesia and you need someone to escort you back to your home for safety. How do we follow up with these folks on their results? Kind of connecting all those pieces. And Judy said, I know the girl for you. So she reached out to me because she knows I'm passionate towards vulnerable populations and overcoming healthcare barriers. And I also have a strong relationship with students, and I'm a faculty advisor for a student group that we do a lot of things in the community, as well as I'm a supervisor for a group of students for the patient navigation program, which is one of our first year classes. So we just started connecting all the pieces, meeting with Hamilton Health, talking about all the steps along the way. How do we logistic-wise make this work? Again, this was all prior to COVID-19, by the way. So these are our numbers prior to COVID. Over the last several months, there was 12 positive FIT patients that were scoped. 5 were Black, 2 Hispanic, 3 Caucasians, and 2 an unidentified ethnic background. 8 patients were found with polyps and removed, and thank goodness we have not found any colorectal cancer yet, but we found several polyps with pre-malignant results. So basically, we're saving patients from colorectal cancer, which is fabulous. So again, these were the results prior to COVID-19. We'll talk about that in a second. Next slide. So what we're doing, we have this program with Hamilton Health and it's moving along. There's been some snafus along the way. Hamilton Health had an electronic health record redo, and that really put them behind on their population management. They're catching up with that. Then COVID-19 happened. So of course, all elective procedures such as colonoscopies were shut down for quite some time at our institution, as I'm sure it is with local institutions near you. And then once we started with our screening colonoscopies and diagnostic colonoscopies again, the question became, well, how do we COVID swab patients before their test? How do we get them back and forth from that? How do we get those results of the COVID test? And how do we plug them into the prior process that we had and tackle all the barriers that were there before? So we're moving forward with all that. And we just had our first successful post COVID-19 reopening scope the other week, and that gentleman actually did have pre-malignant lesions that were removed, which was wonderful. So now that we're reaching out to Beacon Clinic and other free clinics in the area, we'll have a group of students who will identify how to initiate a colorectal cancer screening program through FIT testing at local free clinics, and work with the staff at the free clinic and the patients in order to get them the FIT test and pursue that they've gotten the FIT screening, find out the results, and then plug them into the first the COVID swab, and once negative, colorectal cancer, completing the process by doing a diagnostic colonoscopy. And if their FIT tests are negative, fabulous, then plug them in with a population health management at that site for repeat FIT testing or another option for colorectal cancer screening in 1 year's time. So this slide kind of discusses all of that. Next slide. This is a schematic of the steps that we do. So positive home fit, partner institution, right, referred into for the colonoscopy. There's that COVID testing that's required within, we have it used to be 72 hours, now we're requiring, now Penn State is saying 5 days before an elective procedure to get a COVID swab, and once negative, then they proceed to their diagnostic colonoscopy, escorting the patient home, observing. The students are actually allowed to observe the colonoscopy if the patient is permissive, and often they are. And then the student communicates with the patient about the results, as well as the provider from the home clinic, whether it's the FQHC or the free clinic, about the results. And that's kind of how the process works. Next step. Next slide, I'm sorry. These are our slides. So I think that was about the time that Lynn had wanted. I guess I can pause at this point and see if there's any questions.
Thank you very, very much, Megan. Kate, are we going to go straight through and then do the discussion at the end?
Sorry, I was on mute. I think if we have questions for Dr. Miller now, it might be a nice space to address them.
Okay, and then just let us know when timing wise.
Yeah.
Thank you. Any questions for Dr. Miller? Well, here's one. Ruth?
Hi, yes. I was wondering, have you noticed a difference in the patient's willingness to participate just from being contacted by a student? Does it encourage their participation more? Or do you not have anything to compare that to?
So with Hamilton Health at the FQHC, they have a nurse navigator who traditionally contacts the patients first, tells them about the results of their FIT tests, offers them a program, through Penn State, the partnership, to have a colonoscopy, and then also asks at that point, we have student navigators who can walk you through every step of the process. Is it okay if they reach out to you? Certainly, if the patient has no needs, sometimes all the patient needs is a referral to endoscopy, and that was the one piece that was missing. Those patients just kind of go past all of the stops along the way and pursue the rest. But some patients certainly need issues with transportation to and from the COVID swab, transportation to and from the endoscopy, and then an escort. And then certainly if there's any language barriers as well, we facilitate that with the students. So they don't have to have the students involved, it's offered to them. Sorry. And certainly if they do not.
People please mute. No, you're okay, Dr. Miller. You're getting a lot of feedback from somewhere.
I don't know if to talk for the person. Sorry. Certainly, if the students do not want to involve, if the patients don't want the students' involvement, they don't have to at all. It does not exclude them from the program, and they proceed to their diagnostic colonoscopy or their FIT test when offered through the free clinic that's there. I have found that, to answer your question, Ruth, that most people are very happy to have a student involved because there's a lot of steps in this process. It's very confusing navigating the American healthcare system. So a lot of patients, especially because they're crossing from their home clinic, either their free clinic or their FQHC, and then we're asking them to travel to Hershey and go to Hershey endoscopy and get this COVID swab. All those logistics pieces, patients are very happy to have students involved.
Yeah, I was just wondering if, like, just because they're a student and not like already officially a professional, if patients perhaps felt more comfortable using them.
Yeah, and we're actually, our next step as soon as the IRB goes through is that we're going to ask participants or patients that have been involved with student navigation to do some focus groups and qualitative interviews afterwards to unpack that a little bit, because the theory behind patient navigation is that, you know, patients are just much more easily able to identify. And of course, most patient navigators, most community health workers are from that community, so students are a little different. But anecdotally, I have found that the patients are very happy to communicate with the patients and very happy to talk with them the many steps along the way.
Nice.
We have time for one more question.
Dr. Miller, Jim Williams, do you have Beacon Clinic on your list of community contacts?
Yeah, so Beacon Clinic, actually, we're going to starting that beginning of October. A group of students I've been working with from McLean staff clinic to initiate a colorectal cancer screening program there. So they're our next step over the next several weeks.
Thank you.
Thank you, Dr. Miller.
Absolutely. Thank you for the opportunity for Dr. McGarity and Mary Noel and I to talk about this program.
Well, it was a great presentation. Thanks very much. Okay, next up is our highlights and achievements in lung cancer screening with Drs. Manley and Kumar.
Good afternoon. This is Dr. Kumar from Fox Chase Cancer Center. I hope everybody can hear us well.
Yes.
Thank you so much for this opportunity and presentation. This is a pretty comprehensive program at your end. We were asked to talk and discuss about lung cancer screening. So we're going to split the time between myself and my partner, Dr. Manley here. I'm going to take the first 5 to 10 minutes to discuss some current updates and recommendations in terms of how lung cancer screening has changed and advanced. So with that, let's proceed to the next slide, please. I have no significant disclosures, and Dr. Manley will give his disclosure, but he is a consultant for Auris Health. Next slide, please. So why are we talking about lung cancer and screening? Because lung cancer continues to stay a big problem overall. About 1.8 million cases worldwide with 1.6 million deaths. So you can see in the outer circle on the right side, lung cancer stays one of the biggest cancers overall, about 13% cases worldwide, but certainly the number one killer of cancer patients overall, about 20% or so. A lot of variations in regions, but in particular in the US. So next slide. So this is projected incidence in the US. This year, there's going to be about more than 240,000 lung cancer cases just in the US itself. Most of them are non-small cell lung cancer, about 20% of them being small cell. The problem is the highlighted area in the center. Most lung cancer, as most of us know, is diagnosed at a later stage. And that's when outcomes and prognosis are really poor. And that's been the problem with lung cancer. So while most treatments have advanced significantly, there is still a huge burden of disease. So smoking cessation and lung cancer screening are probably two tools that we have now in the fight against lung cancer. So next slide. So this has now been a 9 to 10 year history in terms of screening for lung cancer. Since the National Lung Cancer Screening Trial came out in 2011, there were different recommendations as to what population to screen based on that. The United States Preventive Task Force came out with its recommendation in December of 2013, upgrading the recommendation to a grade B recommendation promoting screening for individuals between the ages of 55 to 80 with at least a 30 pack year exposure to tobacco, and they should have quit within the last 15 years. The recommendations in terms of stopping were relatively loose. Once it's been more than 15 years since you quit, you can consider not to screen, or if someone develops a condition which limits their survival otherwise, like severe coronary artery disease or severe COPD, that would limit surgery otherwise. Next slide, please. This was mostly shaped by the National Lung Screening Trial results. This was basically a trial done over about 7 years or so, where the population was divided into two, where one set would get a chest X-ray every year versus the other one which would get a low-dose CAT scan. And as you can see, the red line there in the chest radiograph arm, there were about 443 deaths versus the low-dose CT arm, where there were 356 deaths. The trial was actually stopped early because they reached their pre-specified endpoint of reaching a 20% reduction in lung cancer mortality. Interestingly, also, they noticed a 7% reduction in overall mortality, and most of us feel that's related to all the other incidental findings you would see on a screening CT, your incidental thyroid nodules, the incidental kidney cancers, adrenal cancers, or severe CAD that you would pick up. Importantly, I want to highlight is the number needed to screen, which is 320. So which means that you would need to screen about 320 people for about 6 to 7 years to prevent one death from lung cancer. To just put that number into perspective, the same for high-risk breast individuals would be about 250 to 300, and the same number for example, if you would use statins to prevent one cardiovascular death, is about 700 or so. So a pretty robust number overall when you think about screening modalities that are out there in general. Now, besides the NLST, in the last year, there's been many more trials that have come out. The one that has been most significant and deserves mention is the Nelson trial across Europe. And that clearly also showed a 24% reduction in lung cancer mortality, mostly geared towards men. Now, while the Preventive Task Force, and other societies maintain a hard cutoff of age and tobacco exposure duration, there is certainly a lot of discussion and talk about why should it just be limited to this, and what about patients who may not exactly meet this criteria but clearly have other risk factors. So next slide. So as I was mentioning, there is wide variation in risk overall. Just this graph represents different quintiles of risk. The NLST population was divided into 5 different quintiles based on their risk. So you can see at the bottom row there, quintile 5 is a risk of greater than 2%, and quintile 1 is all individuals who are at risk of less than 0.5%. And clearly, the more you can enrich the population that you would want to screen in terms of high risk, the better would be the number needed to screen. Like it's 161 for high risk individuals versus 5,000 individuals in quintile 1. So our efforts need to be geared towards enriching the population where we can provide more benefit than the risks of screening overall. And that's why the field's shifting a little bit more towards possibly using risk-based screening, where it does not involve just a hard cutoff of age or tobacco exposure, but involves other factors. Next slide. So risk prediction model-based selection, there's many different models out there looking at lung cancer risk prediction. I just mentioned a few up there, the SPITZ model, the Liverpool Lung Project, which is the one that's being used in the UK, the ETSEL project, modified PLCO or the Tamamaji model is the one I'm going to highlight a little more. That's been extensively validated now and actually being used in the Pan-Canadian trial, screening trial. That includes different parameters, and I have 7 listed up there, including age, tobacco exposure, history of COPD, a family history of lung cancer, a personal history of lung cancer, or any smoking-related cancer. It also takes into account one's BMI and educational status. Based on this, on these parameters, the risk is classified as either less than 1%, 1 to 2%, or greater than 2%, with greater than 2% being high risk and less than 1% being low risk. Next slide, please. So the modified PLCO model has been shown to be more sensitive than just using the NLST criteria. There's this, I just highlight one paper here. There's many more also showing this. So you can see the sensitivity is about 83% versus the NLST sensitivity of close to 70% or so. What this also helps in, it helps reduce overall false positives, which has been talked a lot in terms of lung cancer screening. Next slide. So this is again a comparison of different models out there. The orange dot at the top that you see is the modified PLCO model, showing clearly it's more sensitive than the other models. Just in comparison, just strictly using the NLST criteria is not as sensitive. That's the rhomboid at the bottom of the graph over there. But again, just to highlight that risk-based screening is probably something to consider strongly when selecting individuals for lung cancer screening. Next slide, please. So let me please skip one slide, and I'll come back to this one. Yeah, so this is the NCCN lung cancer guidelines, and I know it's a very packed slide, but what I do want to highlight is if you can focus on, in the middle column, there's a group 2, where they include that in the high-risk population, anybody who's age greater than 50, has more than a 20-pack-year history of smoking, and one additional risk factor. That one additional risk factor could be anything from the first column, including previous history of cancer, history of COPD or pulmonary fibrosis, occupational exposures like asbestos, and radon, which is probably a big risk factor in, actually the second biggest risk factor in Pennsylvania. Certainly a lot of radon exposure here. So this is the current version of the guidelines. They will probably get updated soon also. I do want to highlight that in the bottom last line, you see they ask for considering using the Tamamaji model to assess risk in particular individuals who do not strictly meet the NLST criteria. The panel over there picked a cutoff of 1.3% as the risk above which you should consider screening. So go back one slide, please. So based on the Nelson trial, some other data, the NCCN recommendations on the United States Preventive Task Force is actually now in draft reviewing, changing their current guidelines overall. So the last paragraph, they'll suggest that this is a draft recommendation, just came out a month ago or so, where they may be changing their recommendation to include people from the ages of 50 upwards based on more recent data. So stay tuned for this. Hopefully by the end of the year, you'll see that the USPFT guidelines now change to include individuals 50 to 80 with a 30-pack-year history of smoking. Or so we'll see where the pack-year cutoff comes out to, but that's the current draft in review right now. Next slide, please. Next slide. So I just wanted to show this as a screenshot for one of the tools that we use here, and we like it a lot. The website is shouldiScreen.com. It's up there in your top left corner over there. It takes you through a series of questions, which includes age, tobacco exposure, family history, BMI, educational status, personal history of cancer or not, and brings out this score. It's very easy to use. I highly recommend this using when you're talking to your patients or clients about lung cancer screening. You can do this within a minute, and that's what comes out as an outcome. You know, this particular patient I highlighted here had a score of 5%, but did not exactly meet the NLST criteria. Clearly a high-risk individual. What's also good about this website is you can use this as a shared decision-making tool and explain to patients both the risk and the benefits of screening. So I think this is something I just wanted to share and throw it out there. It's really is risk model based screening. Next slide, please. So here at Temple University Hospital and Fox Chase Cancer Center, we tried to see how we could improve the experience of any particular individual coming through screening. There's many ways out there. Certainly overall, the country, there's many programs now. There's one particular aspect I'd like to highlight about our program, which really we felt help individuals a lot. So in our process, a patient or a provider can refer into a thoracic navigator who then schedules the patient to come in for a provider visit, the center green box there. What's important is meeting with the provider, our patients then can then get a low dose scan the same day and see the provider back within half an hour after getting their scan. Doing screening this way really takes care of a lot of issues downstream. Number one, it addresses a lot of anxiety-related concerns waiting for results. Anything that is to be addressed can be addressed right there and then at the visit with the provider again, where hopefully most of the times it's just rescheduling screening, so that confirms and affirms that we can give them an appointment for the next year, which is very, very important. Just doing one scan is not enough. You have to take them through the whole process every year or every other year or so. Or because we run this in collaboration with our smoking cessation program and our nodule clinic, we can really channel patients into the same day or within the next few days into seeing the right provider, whether it's short-term imaging or having to see our surgeons. So doing this all together in one day has a lot of advantages. Next slide, please. So I'd like to start with this slide for me. So, just to mention that the screening should not be taken just in isolation. It's a comprehensive program. It should involve 4 equal parts. It's the team of navigators that helps you bring patients in, enriches the population so that risks and benefits of screening are overall favorable. It's a teachable moment to discuss smoking cessation. So integrating screening with the smoking cessation clinic and a nodule clinic and community outreach is all equal parts of this program. So over the last few years, certainly in the greater Philadelphia region, there's been a lot of progress with lung cancer screening. There are about, I want to say, 50,000 to 100,000 patients who meet eligibility criteria and are at risk for lung cancer. When we first started this about 7-8 years ago, we had just started and there were barely a few programs. Now I want to say there's about 20 good programs within close to the greater Philadelphia region with our program, the programs at Jefferson and Penn, certainly significantly high volume programs, and have been picking up lung cancers. I mean, we ourselves have picked up quite a few patients now with early stage lung cancer, and certainly this is starting to make a significant impact in society overall. So with that, I'll stop here. I'm going to pass this over to my partner, Dr. Manley, who leads our interventional bronchoscopy and advanced nodule diagnostics program, to just highlight all these difficult to approach nodules. I mean, we have some new tools now which are helping, push the edge here in terms of early diagnosis. So thank you all for your attention. This is Dr. Manley on here.
Thank you, Dr. Kumar. Can you go to the next slide, please? So when we find a lung nodule in these screening CTs, the question is always what to do about it. And part of the workup is the diagnosis, and the other part is the staging. So when we think about diagnosis, we want to get a biopsy or a representative sample of the lung nodule. But we also want to know if any regional lymph nodes are involved, because that changes our treatment algorithm completely. If a lung cancer is contained to one small section of the lung, we can refer the patient to surgery or radiation, and we're pursuing cure. If the lymph nodes or there are distant areas of disease, then we're no longer talking about cure and we're talking about treatment. Now, the difference is can seem small, but it's very meaningful for the patient. So doing accurate diagnosis and screening is important. We do our lung nodule diagnosis by robotic bronchoscopy. It's a thin, flexible fiber optic camera that we can drive out into the periphery of the lung to do the biopsies under good control and stability. And then we do our lung cancer staging by evaluating the lymph nodes by ultrasound. The scope on the bottom right of the screen is what's called an EBUS, or endobronchial ultrasound scope. So we look at the nodules under ultrasound and then do biopsies in real time. Next slide, please. So I want to show just 2 short cases which really exemplify the importance of accurate diagnosis and screening. This first case, the patient came in very concerned after this incidental right lower lobe lesion was found on the screening CT. He had been offered a surgical lobectomy right off the bat by an outside physician, and he came to us for a second opinion. Next slide, please. When I drove out to the lesion, you can see I'm 16 millimeters away from this lesion, and the radial ultrasound picture on the bottom right shows that we're in the lesion. And you see this red sort of beefy rind covering the area of concern. Next slide, please. When I peel away that red rind, I get frank pus back. So this was not a lung cancer. It was most likely an abscess or a lung infection. Next slide, please. You can see that a CAT scan just a few weeks later showed that this wasn't a lung cancer at all. He did not need a surgeon. He did not need a cancer center. He just needed some antibiotics and time. And so being able to evaluate these by first seeing the nodules up close and being able to probe them and investigate them, and then being able to do the biopsies under good stability control is very important. Next slide, please. Conversely, this is a patient who only had a history of prostate cancer, was a smoker and had a new lung nodule. And he'd been told by his primary doctor this is likely prostate cancer and really shouldn't be something of concern. Next slide, please. When we drive out to the lesion, we find a small airway that's sort of prolapsed closed. And we see we're about 38 millimeters away from the lesion. Next slide, please. And as we move into the lesion, we can start to dilate that airway open in front of us. Next slide, please. And as we get closer and closer, you can see the airway opening in front of us. Next slide, please. Now, as we start looking at this airway, next slide, please. We can drive closer and closer to the lesion. We have that lesion. You can see the CAT scan views giving me the directionality that we need to pursue, and then the bronchoscopic views on the left side. Next slide, please. So now we're 6 millimeters away from this tiny lesion. You know, we can now biopsy under good control. The alternative is to do a CT-guided needle biopsy, but this, as you saw, the lesion was very deep in the lung and very close to essential structures. Next slide, please. So we're able to put out a very tiny needle into this lung nodule. And we can biopsy it under direct visualization and control bleeding and get a good sample. Next slide, please. You can see the bleeding afterwards because we use such a small needle is very small. Next slide, please. And you see this patient had a lung adenocarcinoma. Now, when he was evaluated by endobronchial ultrasound, his lymph nodes were negative, and so we could pursue curative resection. If the lymph nodes had been positive, then the treatment algorithm becomes chemotherapy and radiation. We get enough tissue to evaluate for mutational analysis and then potentially enroll in clinical trials. And so you can see in this one anesthetic period, we're doing diagnosis and staging. And when you combine that with lung cancer screening, smoking cessation, nodule follow-up in clinic, we get very good comprehensive care for these patients. Next slide, please. Thank you. We'll take any questions.
Questions for either Dr. Manning or Dr. Kumar? I think you both did a very thorough job in your presentations. There doesn't appear to be any questions.
That's a good sign. Thank you so much.
Thank you. Thank you for spending the time sharing with us.
We're happy to answer things if they come along later via email or so, and certainly more than happy to chat on things later. Thank you so much again.
Thank you both. Have a great afternoon. All right, then moving right along. We're now going to hear about hepatitis, and our speakers are Lauren and Susanna. And so I think, Lauren, you're going to kick it off.
Sounds
Or I'm
good.
wrong. I guess it's Susanna.
No.
It's Susanna. Hi, this is Susanna. Can everybody hear me okay?
Yes.
Awesome. So I'm Susanna Masardis. I'm the Executive Director for the Community Liver Alliance, and we are the administrator and fiscal agent for Free Pennsylvania Coalition. The coalition was formed to develop and implement an advocacy strategy that will support the Pennsylvania Department of Health viral hepatitis elimination plan. We work in tandem with the Department of Health viral hepatitis coordinator, and it's my pleasure to introduce my colleague, Dr. Lauren Orkis. She is the viral hepatitis prevention coordinator for the Pennsylvania Department of Health.
Thank you so much, Susanna. And thanks so much for the invitation to present today. Thanks to Brenda for connecting us. I think that this is an important topic, as Brenda had highlighted in the morning, related to liver cancer. And I'm really excited just to speak with all of you and get this conversation started this afternoon. So today we're going to be just generally talking about hepatitis elimination goals, national strategies, and then down to the local level. And we're going to be talking specifically about how feasible elimination is in Pennsylvania and how that also relates to liver cancer. We'll be talking in depth about hep-free PA, the establishment of it, players, including those with more of an oncology focus. And we can talk about how liver cancer fits into our draft elimination plan as well. And then we'll be highlighting some action items and next steps at the end here. So next slide, please. So generally, hepatitis, viral hepatitis B and C can develop into chronic conditions and are very burdensome worldwide and of course here in Pennsylvania as well. But viral hepatitis has been deemed a condition that can be eliminated. So we wanted to just briefly touch on some of these definitions. So WHO has gone as far as developing some metrics and definitions around viral hepatitis elimination, and their ultimate vision is a world where viral hepatitis transmission is stopped. So that's what we mean really by elimination, and everyone having access to safe, affordable, and effective treatment and care. Of course, this is not eradication, this is elimination, so we have to think about it in those terms of transmission really being stopped. So we're trying to prevent new infections and treat those existing infections. And we know that viral hepatitis, as I said, is very burdensome worldwide. I'll talk in a second about Pennsylvania. But we know at this point that elimination is feasible because of tools that we have now, including vaccine for hepatitis B, treatment for hepatitis B, not cure, but treatment. We are emphasizing the need for harm reduction strategies. So those would be safe injection practices, also safe blood, as we know lots of viral hepatitis. Oh, I think we lost our slides there for a second.
My apologies. I will take care of this. What's going on here? So bear with me one moment.
That's okay.
And to our participants, if you are switching screens, just be mindful of which ones you may be switching and taking by accident. So let's just.
That little button pops up easily there.
Yes. So we will just get right back on track.
That's okay.
It makes us go through every single one.
That's okay.
Okay, were we one slide back, correct? Right
Yes,
here?
one more. Yep. So just because of the tools that we have now currently, we know that elimination is feasible. There's been lots of modeling around this fact, and we know that it is feasible because we have vaccine for Hep B, we have treatment, we have harm reduction strategies. And as I was saying, we know that lots of hepatitis C was transmitted when we did not have safe blood products. So but prior to 1992, we now know we do have tested and safe blood products. But that's an important piece to keep in mind, that lots of people got hepatitis C through blood transfusions, et cetera. But around the harm reduction piece, we have tools in our toolbox related to clean needle exchange, clean works in general for people who inject drugs. So that's PWID there. Safer sex is important.
Lauren, my apologies. I muted by accident. So if you could take yourself off of mute and come back.
Sorry.
That was my fault. My apologies.
That's okay. That's okay. Did you hear me talk about harm reduction? I'm sorry, I don't know how long
Just started to do that. My apologies.
Okay. Yeah, that's okay. So yeah, we know that we have tools in our toolbox related to harm reduction for people who inject drugs and who use drugs in general. And we know that this is an important prevention piece around, clean needle exchange and clean works exchange in general. And we know that safer sex is also an important prevention aspect, as we know that hepatitis B is definitely something that we know is transmitted via sex and of course childbirth, but hepatitis C as well can be transmitted via sex, especially for folks that are co-infected with HIV. And one of the bigger reasons I think that a lot of this has come around elimination has really come to the forefront is because we have cure for hepatitis C now, direct acting antivirals, DAAs for hepatitis C that were not available several years ago, that are very, very effective now, upwards of some drugs 99% cure. So it's very exciting, and nationally we have developed an elimination strategy developed by NASEM and HHS that give us some metrics, and ultimately we're looking for 90% reduction in incidence, and if we can do that, then our definition of elimination can be met by 2030. Unfortunately, we nationally, in many states specifically, are not on target to meet these 2030 goals. Next slide, please. So this is an HHS map that highlights states and jurisdictions that have elimination projects underway. So they are convening stakeholders, they're writing elimination plans, and some jurisdictions have been working on this for many, many years and are much further along than other jurisdictions. Pennsylvania is not highlighted on this map. We're working to get us highlighted on this map for both B and C, which is, a little bit more rare that we'd be tackling both in our elimination planning efforts. But it's really, what HHS and our CDC partners want us to move towards. So when we talk about, folks being sort of at different stages, we know that Washington State has a very robust elimination plan and an excellent roadmap and buy-in from their governor as to, how they might eliminate hepatitis C in their state, but they have not yet been able to obtain state funding. Viral hepatitis is historically very underfunded on the government side of things. But New York State actually got buy-in from Governor Cuomo in the last couple of years to fund their elimination strategy statewide at $5 million a year. So they're a state that's further along, and they're now, with that buy-in from the governor, moving forward with writing and finalizing their elimination plan. On this map, we have 2 dots for Pennsylvania. So the Philadelphia Department of Public Health, in collaboration with lots of community stakeholders, has a group called HepCap, which is an elimination-focused group run out of Philly, of course, and then more newly established Hep C-free Allegheny that Susanna leads in coordination with the Allegheny County Health Department are highlighted both on this map. And so statewide, again, we're in the early stages of all this development, but are partnering closely with both of these local elimination projects. Next slide. Okay, so is elimination of viral hepatitis B and C feasible in our state? It definitely is. We have lots of, positive things going on across our state that make elimination feasible. But we do have a very stark burden of viral hepatitis B and C in our state, particularly hepatitis C. related to substance use disorders. We get about 20,000 plus new cases of hepatitis C reported in our state every year. And I would love to work closely with Brenda and others to marry some of our data on our infectious disease side with cancer registry outcomes as well. So we'll be working on that, I'm sure, going forward. But hepatitis B is, of course, an issue as well in various parts of our state. But despite our, higher burden of disease, we have lots of different partners across our state that have been working on this type of elimination work for many, many years. We also, since 2018, were one of many states to lift restrictions around Medicaid paying for hepatitis C treatment. So they lifted sobriety restrictions. They lifted the restriction around how sick you had to be. So you don't need to have an elevated fibrosis score. You can have an F score of 0 now to receive treatment. And they also lifted some restrictions around who could treat. So we are in partnership with several different groups. The state is always trying to increase the availability of providers. So Susanna is really an expert in this area and has led several trainings across the state over the last several years to increase the number of PCPs that can treat for hepatitis C. And luckily, we've also expanded treatment for hepatitis C in our state prison system over the last couple of years, and now they're on their way to eliminating hepatitis C in the prison population. And as I mentioned, we have those 2 more city and county specific HCV elimination programs to partner with us on this state strategy. And we do have some harm reduction programs in our state. If you're familiar with Prevention Point Philadelphia and Prevention Point Pittsburgh, those are the 2 legal harm reduction service organizations in our state, and we are working towards legislation to make syringe service legal statewide. And then we're lucky enough also to have the Hepatitis B Foundation located in Doylestown, Pennsylvania, and they're really close partners of ours around this initiative and making sure that hepatitis B is addressed adequately as well. And then we have several engaged health officials at state and city levels that want to make elimination a priority, which is always extremely helpful. Next slide.
Hi, this is Susanna. I'm going to talk a little bit about developing our statewide coalition. So, actually it was through our advocacy at the P&T committee meetings that that HepCap in Philadelphia and HepFree C Allegheny County elimination groups came together to advocate. We brought together patients and providers and other experts to testify several times over the years to bring down those barriers that Lauren spoke about earlier. And so when we were able to pull together a summit May of last year under the Pennsylvania Department of Health, we pulled together all of our stakeholders and colleagues that we knew and new folks. And so we were just well on our way. Everybody was really excited about joining the coalition. So we've had monthly coalition meetings and we were really hit the ground running, and then COVID happened. So we just started, breaking into smaller groups and, really trying to figure out, what can we do in this age of COVID and still keep the elimination plan going? Because many of our frontline providers that are helping to lead this coalition and the work that Lauren's doing with the State Department of Health were pulled to address COVID. So we created a survey and submitted that to the coalition members and community, and it's intended for clinicians who provide viral hepatitis testing and/or care, community-based organizations that provide viral hepatitis prevention, outreach, and testing, and navigation services, and health department staff who manage viral hepatitis activities. And the purpose of the survey is to better understand how the COVID-19 pandemic has impacted viral hepatitis services in Pennsylvania, and all our responses are anonymous. So our goal is to really determine the impact, challenges, and barriers to current viral hepatitis services in Pennsylvania, and to understand resources that would be helpful in overcoming those challenges. So we had some great activities planned. We had a Hill Day planned for March, and a screening day planned for March. And so those are on hold until further notice. But in the meantime, we're still moving our efforts ahead. Next slide, please. Our coalition members are led by two co-chairs, Dr. Stacy Truskin, who's medical director at Philly Fight, which is an FQHC in Philadelphia. And she's an eminent expert in treating hepatitis C, hepatitis B, HIV, all the virals, and really just one of our leading experts to help us move this forward. And then on the other side is Sherry Cohen, Dr. Sherry Cohen, and she's the Senior Vice President with the Hep B Foundation and Hep B United. And so we are marrying Hep C and Hep B experts to help lead the charge. And we have more than 300 coalition members. I know Lauren and I were both really excited when we did have the summit and the response that we had, and new people who came. We have, as you can see, I'm not going to read the list, but it's really well represented stakeholders. And the most important part for us is also people with lived experience and their caregivers, so that we can raise a voice for those who are, experiencing viral hepatitis. So we're working together to create a pilot town hall for folks who have lived experience. And so we'll hope to glean information from that, and then we'll do more across the state to activate and center the voice of the consumer. And one of our coalition members, and of course, this is a cancer meeting, and it is very important for us to talk about liver cancer prevention and also liver cancer surveillance and linkage to care. So, we know that late stage cancer is profoundly deadly, and, we know that as we approach the 50th anniversary of the war on cancer in 2021, it's important to acknowledge that a critical front in this war must advance viral hepatitis elimination efforts to increase screening and linkage to care for viral hepatitis B and C, and increase adult vaccination for viral hepatitis A and B. And we have a provider, Dr. Kenneth Rothstein, who's with Penn Medicine, who is championing hepatocellular carcinoma screening and linkage to care. He's working on a pilot with Pennsylvania payers to support routine screenings for at-risk patients. And he always keeps our eye on the prize with respect to liver cancer, because we know that hepatitis C contributes towards 50% of U.S. cancer incidents, and hepatitis B is responsible for 15% of those incidents. And according to the CDC, hepatitis screening and treatment not only helps prevent liver cancer, but it protects people from a host of other health complications. And we know that overall diagnosis and treatment reduces the risk of all-cause mortality among individuals with hepatitis C by 50%. So we're ensuring individuals at risk have access to prevention, testing, and treatment could dramatically reduce the severe burden of viral hepatitis and drive down liver cancer incidence and death rates in the United States. So this isn't just about eliminating viral hepatitis, but it's also about reducing the incidence of liver cancer as well. Next slide, please. So we do have future plans. We are looking to a bright future once we get past the pandemic, and we are working on our advocacy efforts, and we do want to bring back our Hill Day and our annual viral hepatitis screening day. We started having legislative meetings, but we're working on a letter writing campaign and providing other educational forums and planning these town hall events as well. And then I think I might have skipped one of my slides. And we also presented a budget earlier this year. And the coalition chairs and I met with our budget secretary in January of 2020 to submit a request of $15 million to support our efforts, and that would be $5 million over 3 years. And the things that we are asking for is for prevention, for viral hepatitis prevention among youth, women of childbearing age, and other emerging high-risk populations, testing and linkage to care and patient navigation to support community-based organizations. We also want to expand the treatment programs in primary care settings and substance use disorder treatment programs for Hep C and Hep B infected persons. Expand provider training and other educational opportunities for medical providers for testing and linkage to care and for their staff. And we want to develop and implement a viral hepatitis awareness campaign to inform and educate the public, medical and social service providers. And we also want to invest in and extend existing PA viral hepatitis care in state and local correction facilities to include hepatitis C prevention, opt-out or universal Hep C screening and support services. And of course, surveillance is always so important in any of these endeavors, and we're asking for money to invest in statewide surveillance in our budget. Next slide. I think I did talk about this in a little earlier. Put the cart before the horse, but we are planning and hope to look at the future in a new lens and learn so much during this pandemic, and how we could be more effective and really thinking about how COVID-19 relates to our population, to liver disease, to viral hepatitis. So I thank you so much for allowing me to present this information to my esteemed colleagues on this call.
Any questions for Lauren or Susanna? Thank you both for some very enlightening information. I think all the speakers just were a wealth of knowledge and gave us some very good examples of programs or efforts or initiatives that are working or are moving in the direction to be more effective, and also with a lot of future things for all of us to give some thought to. Wow, there's lots to be done, and it was very interesting to me that each of the presentations did address something in relation to health inequities and disparities. So it seems to be becoming more and more of a focus on lots of people's minds. Kate, I don't know if now, I know we wanted to have time so we could have conversation. Do you want that done now, or do you want to hold until survivorship presents?
I mean, I think if there's conversation to be had, we could take a couple of moments here to do some quick conversation, if that's okay, Lynn, before we then move into the
Absolutely. I think maybe I can just start it off. I mean, what we heard were some very innovative programs, information on them. But I know, working at my own institution, we have something very similar for colorectal cancer that we've put in place. And it did take time, and it did take a lot of interdisciplinary collaboration. But once you get the ball rolling and you get the right people in the room, it seems to me if you really have people that are truly interested in early detection and screening and prevention, then you can move things forward. We too have a free colonoscopy program, and we have similar things in place. As we heard about earlier, it did take a number of years to get that developed, but I think it can be done. It just takes a good bit of effort and the right people. And when you have examples like those that were presented today, I think that gives all of us some fuel for thought. Other comments, other things going on, maybe not directly related to what we saw, but along the lines of colorectal screening or low-dose CT for lung cancer screening, or with the hepatitis B and C.
Well, this is Susanna. I would just like to, and I forgot to, invite everybody and anybody to join our effort. If there's something particular that you can offer to the coalition or that we can help you with, you know, the more the merrier. And I think that there's strength in numbers. So we do, Lauren and I do invite you and or your colleagues to, you know, think of us as collaborators, a resource, or join our team to help us move this effort forward.
Thanks, Susanna. I know I work with a lot of populations that are Hep B and C positive and have spent long before I knew about you, a lot of time of it and energy to help them get coverage and to help them get right care because they're not insured. So now I have another collaborator that I can refer to and can also hopefully collaborate with.
Terrific.
Sounds good. Thank you.
Well, if there are no other questions, then I don't want to hold up the next group of presenters. So I guess it's for Ruth to take away.
Sure. And just to the next panel, if you're okay with starting a little bit early, I see that you're all here. If that's okay, we can jump right into our next panel. So
this is Ruth. I think it's okay if we get started earlier. That gives us more time to chat because I think we're going to have a decent amount to chat about here.
Absolutely. So Ruth, I'm going to officially turn it over to you. I'm going to advance the next slide to welcome our next panel of speakers.
Wonderful. Thank you so much. Hi, my name is Ruth Modulewski. I am the mission coordinator at Susan G. Komen Greater Pennsylvania, and I have had the great honor of being able to work with all three of the women who will be speaking this afternoon with us. We're going to be data light and experiential heavy. All of these women bring something special to the table and to the discussion about survivorship and, you know, support groups and how that has happened and changed with regard to COVID-19, the overarching theme of today. Our speakers include Colleen Dwyer, who's the clinical director at our clubhouse, and she will speak more specifically about metastatic breast cancer support program that is run out of our clubhouse. Wendy Myers, who is the director of counseling at the Cancer Caring Center, who has developed a telecounseling program that I have found incredibly interesting. So she was kind of a little bit of ahead of the curve, if you will, with regard and ready to roll whenever COVID hit. And Yolanda Murphy, who has a vast experience, is a breast cancer survivor herself, but has a vast experience in working with a variety of groups and is here as a representative of the Young Adult Cancer Survivors United and Young Adult and African American Support Group, Survivorship and Support Group. And the next slide, please. And so these are the three groups that are represented. Let's go to the next one. What I hope to do now is just, I will give a brief introduction, and the first slide will be like all of the programs in the organization, and then the following slide will be for the specific person to talk a little bit shortly about the main group that we've brought them on to this panel for. So first up is Wendy Myers, who I mentioned before, and the Cancer Caring Center has a 32-year history in the Pittsburgh area of providing a variety of support services that you see on this slide here. And it is not only is the organization provided cancer support groups, but also some wellness. And as I mentioned before, the private counseling that Wendy provides. So if we give the next slide, and Wendy, if you could talk a little bit about your private counseling sessions.
Sure. Thanks so much for including me. Good afternoon to everybody. And I feel honored to be here to share with you some of our great programs. So I am a licensed clinical social worker and have been a medical social worker for a number of years, and have been at the center doing support groups for 20 some years, but have actually done their director of counseling for 10. So I typically have provided one-on-one counseling for patients and families and couples, and usually in person, which has been, you know, the mode of operandi. But I've also in the past started to do some telephone counseling just because there are a lot of people that could not get into the center.